طيب, let's go live, please.
لايف دلوقتي يا دكتور.
Hello, everyone. It's my great pleasure to welcome you today for the Saturday Satellite Symposium, which is organized by Saudi Society of Blood Disorder in collaboration with pharmaceutical company. So this is the first time we conduct a dedicated symposium for pharmaceutical companies with an aim to increase the knowledge in the field of hematology. My name is Firas Al-Freih. I'm a hematologist at King Faisal Hospital, as well as the president of Saudi Society. I hope that you have been having a fruitful meeting. So in today's session, it will be divided into lymphoma, lymphoproliferative disorder, as well as infection, the first session. The second will be about acute leukemia, followed by a session on chronic leukemia. The first session, it will be lymphoproliferative disorder as well as infection, will be moderated by Dr. Amal Bayhani. Dr. Al-Bayhani is an adult hematology consultant, as well as chairman of medicine at King Faisal Specialist Hospital in Medina, as well as she is the vice president of Saudi Society for Blood Disorder. First, so Dr. Bayhani will be moderating the first session along with me. Moving forward, it is my great pleasure to welcome introduce Dr. Binyam Osman. Dr. Binyam Osman, he is an adult hematology consultant at King Faisal Specialist Hospital, as well as he's a team lead for myeloma. So Dr. Osman will be giving a satellite talk about Amgen satellite talk, which will be how to treat lenalidomide sensitive myeloma patient for the next 25 minutes. I would like to encourage attendees to post their questions as we go, and we'll try to address them. Dr. Binyam, the floor is yours.
Bismillahir Rahmanir Rahim. Assalamu alaikum jamian. I would like to thank Dr. Firas for the kind introduction and Dr. Amal for arranging such a successful meeting. I will also want to thank SSBD and Amgen for giving me this opportunity to discuss this niche group of patients, which is lenalidomide sensitive myeloma patients in first relapse and beyond. So this is my disclosure and Amgen's disclosure. So currently we have a wide array of medications to treat myeloma that have been approved. And in the PI family, we have bortezomib, carfilzomib, and ixazomib. In the IMID family, we have thalidomide, lenalidomide, and pomalidomide. We have 3 monoclonal antibodies approved as well: daratumumab, both IV and subcut, isatuximab, and elotuzumab. The antibody drug conjugate, which is showing great efficacy, belantamab mafodotin. Approved CAR T cells include ide-cel and the latest cilta-cel, and other agents such as selinexor and panabinostat. This is in addition to the traditional agents available like steroids, alkylators, and chemotherapy regimens. The other novel agents that is available to use and in development are the melphalan agent melflufen, which is a combination of peptide and the drug. Then we have access to venetoclax to be used in the 11-14 patients. A newer IMID by the name of iberdomide is showing great promise and is in development. Then there are other antibody drug conjugates which are non-BCMA in addition to the belantamab. Bispecific antibodies, cevostamab, talquetamab, and other CAR T cells in development. So just as a reminder, the first line treatment for myeloma is usually initiated, as shown in the yellow boxes, when there is a either crab features or any myeloma defining events, such as more than 60% plasma cells on bone marrow, the involved to uninvolved free light chain ratio of more than 100, or MRIs showing more than one focal lesion. Some authors, such as Dr. Rajkumar, whose slide I'm presenting here, suggests treatment for high-risk smoldering multiple myeloma as well. So currently, I think all over the world, both in Europe and North America, it is widely agreed that for a transplant candidate who is newly diagnosed with myeloma, we either use a regimen with VRD or DARA-based quadruplet induction if it's high-risk patient, followed by autotransplant and maintenance with either lenalidomide for standard risk or lenalidomide and bortezomib for high risk. In this slide, Dr. Rajkumar is suggesting that some standard patients could have delayed transplant. And in the case of non-transplant patients, his suggestion is VRD for 6 months followed by len maintenance or daratumumab Revlimid dex. This is a similar slide by Philippe Moreau from France. So on the other side of the Atlantic, it is similar. Transplant candidates gets VRD or DARA-based cord induction, or if Revlimid is contraindicated or not available, VTD, VCD, followed by autotransplant and maintenance with either lenalidomide for standard risk or lenalidomide and PI for high risk. He also suggests tandem transplant for high risk, but says no role for delayed transplant outside clinical trials. And for non-transplant candidates, the suggestion is a firm DRD or VRD followed by lenalidomide maintenance. Coming on to relapse myeloma, it's another debate whether biochemical relapse needs to be treated or not, but clinical relapse would mean new bone lesions or plasmacytomas, or the definite increase in the size of the existing lesions, then the crab features, and also other myeloma defining agents. So once they have relapsed, then at first relapse, the choice of therapy must consider what the patient received in the first line and the likelihood of the disease being sensitive or refractory to the prior agents. So in general, a refractory disease is defined as myeloma progressing on or within 60 days of receiving standard doses of a specific therapy. We know that lenalidomide use has increased all over the world in all lines of therapy. If you look at the clinical trial evidence on the left-hand side, we know already that in both transplant eligible and ineligible patients who are newly diagnosed, continued Revlimid maintenance does improve progression-free survival and overall survival. And in real world, we can see that the IMiD-based regimens are increasing in all lines of treatment. And in a registry-based study from US, the people who were newly diagnosed received up to 52% of them received lenalidomide. So how do we define lenalidomide sensitivity and refractoriness? Lenalidomide refractory can be defined as those patients with myeloma progressing on or within 60 days of receiving standard dose of lenalidomide, which is 25 milligrams daily. And the other patients can be considered sensitive if they have received lenalidomide, but not in the last 60 days, or they were on a maintenance dose of single agent lenalidomide 10 milligram daily. Because such patients, these lenalidomide sensitive patients, may benefit from increase in the dose of lenalidomide or an reintroduction of dexamethasone or a third agent being added in. What are the possible scenarios? These are the ones I could think of when you say a patient could be lenalidomide sensitive. The patient received lenalidomide-free regimen upfront, like VCD, VTD, VMP, etc. The patient was on bortezomib maintenance rather than Revlimid maintenance, or the patient was not on maintenance, or as we mentioned earlier, lenalidomide received previously but not in the last 60 days, or as a single agent at 10 milligram. The NCCN guidelines recommends all of these regimens put into one box for previously treated multiple myeloma at relapse, which is not easy. I mean, there is category 1 recommendations, but it is not easy to pick an appropriate choice because all of them have been put into one box. ESMO takes a different approach. They have divided the patients into who have relapsed into patients who have relapsed after VRD, or patients who have relapsed after DARA-RD, or patients relapsing after DARA-VMP or DARA-VTD. And each of these groups have been subdivided further. So if you look at the VRD patients who relapse, they have put it into either lenalidomide sensitive, lenalidomide refractory, bortezomib sensitive, and double refractory. So this is a much more practical way of looking at what could be the best next line of treatment. So this is another slide from Dr. Rajkumar. If you concentrate on the yellow boxes, at first relapse, if the patient is lenalidomide sensitive, he firmly recommends DRD. And if the patient is DARA refractory, then KRD or ixazomib RD. Similar slide by Philip Moreau. You can see a lenalidomide sensitive patient at first relapse, firmly DRD as a first line option. And alternatives include KRD, IRD, elotuzumab RD, KD DARA, and KD ISA. This is a systematic literature review and network meta-analysis. They also identify that DRD seems to be the most effective 3-drug regimen in the lenalidomide sensitive patients, as illustrated by the hazard ratio for PFS. You can see the lowest HR is for DRD at 0.13, followed closely by KRD and the rest. It is not fair to compare between trials, but I'm using this slide, which looks at 4 similar trials, Tourmaline MM1, Eloquent-2, Aspire, and Pollux. In the Tourmaline, the comparison was between IRD, ixazomib RD versus RD. Eloquent looked at elotuzumab RD versus RD. Aspire looked at carfilzomib RD versus RD, and Pollux looked at DARA RD versus RD. As you can see in the Pollux column in red, the overall response rate, VGPR rates, and median PFS were all superior in the DARA RD arm. So the median PFS in DARA RD was 44.5 months, which is very impressive, as against the, let's say, KRD, which is 26.3 months. Let's have a look at the Pollux extended follow-up study. So this was 569 patients randomized to daratumumab, lenalidomide, dexamethasone versus Lendex. The patients were treated until progression, and the patients were included if lenalidomide was given earlier, but not lenalidomide refractory. On the left-hand side, you have the median PFS of all patients. So the median PFS is 44.5 months. In those patients who were lenalidomide exposed, the median PFS is still a respectable 38.8 months. Those patients who had only one prior line before the DRD, the median PFS is not reached. And in those who have Velcade refractory disease, the median PFS is 34 months. In high-risk patients on the right-hand side, you can see that the median PFS is 26.8 months. So if you look at the high-risk cytogenetics as defined by 414, 1416, and deletion 17p, the Pollux gives a median PFS of 26.8 with DRD, followed by Aspire with KRD at 23.1 months. So the conclusions regarding high-risk cytogenetics at first relapse in the lenalidomide sensitive setting is that none of the triplet regimens shown can completely overcome the high-risk cytogenetic findings. So either DRD or a combination of a PI and an IMID like KRD or IRD is a good choice in patients who have high-risk cytogenetics. And if it is available, a quadruplet regimen can also be considered. This is Aspire trial looking at KRD versus RD. The important thing to remember is that when the trial started, the long-term safety data of carfilzomib was not available. So it was designed so that the carfilzomib would be stopped after 18 cycles and lenalidomide would be continued until progression. So unlike the Pollux and other trials where the active agents like daratumumab and ixazomib and elotuzumab were continued until progression, in the Aspire trial, the carfilzomib was stopped at 18 months. And you can see on the left-hand side, in the younger patients less than 70 years of age, the progression-free survival was 28.6 months. And in the older patients, it was 23.8 months, and both showing PFS advantage. Moving on to the Eloquent trial, looking at elotuzumab RD versus RD. PFS was noted at 19.4 months in all patient group. And the overall survival was 48.3 months. And the last trial that we will look at today is the Tourmaline MM1, looking at ixazomib, Revlimid Dex versus Revlimid Dex. So one randomization of 722 patients, and they were all receiving it until progressive disease or unacceptable toxicity. So the median PFS in this case was 20.6 months in favor of IRD. And the PFS benefit was seen in all the subgroups, including cytogenetic high-risk groups and previously PI and IMID exposed groups. So just looking at this probably unfair comparison, but it looks like the 44.5 month PFS with the DARA RD seems to be much higher than the other regimens. At second or higher relapse, the choice of drugs is based on what they have received previously. So any two new drugs with a triplet is preferred from second relapse onwards, which can be any of these agents, ESA, PD, DARA, PD, KD, DARA, KD, ESA, and so on. And then there are always additional options based on availability and factors such as 11, 14, like venetoclax. So we have the CAR T cells, belantamab, selinexor, chemotherapy, bendamustine-based regimens, elotuzumab, panobinostat, and cyclophosphamide and dex. This is a slide from Dr. Moreau, and it's a similar slide from Dr. Rajkumar as well. From second relapse onwards, two new drugs with a triplet is preferred. I'd like to complete with a case study. This is a patient of mine. He's 69-year-old now. In September of 2016, he received renal transplant. And the renal biopsy, which was done prior to transplant, showed interstitial nephritis and glomerulonephritis. There was no evidence of myeloma or casnephropathy. And the myeloma screen was negative, except they didn't do free light chains at that time. Later on, in April 2018, there was a CT spine which was reported as extensive bone resorption and osteoblastic activity at T11 with compression. And the suggestion was, could this be due to renal disease? The patient continued on immunosuppression for the renal transplant with mild CKD. In February 2019, so almost 2.5 years after the renal transplant, he was diagnosed to have lambda light chain myeloma with 1114 translocation. So the bone marrow and trephine showed heavy infiltration with plasma cells, and renal biopsy of the transplanted kidney, which is now in February 19, showed myeloma cast nephropathy and lambda light chain deposition. MRI spine showed T11 bony lesion and involvement of the neural foramen with compression of the lower cord and edema. So the patient was started on VCD, which he received for 8 cycles. He was considered for bone marrow transplant as consolidation. However, the renal physicians at that point were not sure what would happen to the kidneys, and so they were not in favor, or they didn't give the clearance for us to go ahead with the auto BMT. But I think at this point now, if we have a patient who has had renal transplant previously and they develop myeloma, we will happily give an auto BMT for such a patient. So after 8 cycles of VCD, he was given VD maintenance from October 19 until March 2020. And the reason why we stopped the Velcade maintenance was because of a relapse, which was a oligosecretory or non-secretory relapse, whereby he actually came in with severe back pain and AKI. We did a bone marrow and it showed 80% plasma cell infiltrate. And the CT scan showed new fractures, new multiple lytic lesions. So it was clearly progressive disease, but the the light chains didn't go up, neither did the monoclonal protein. At this moment, we did not have daratumumab due to a shortage. So the next line that we started was KRD. He tolerated KRD with difficulty. So remember that he was already on immunosuppression for the renal transplant. He was having cytopenias and recurrent infections, and he also developed a PE while on these 7 cycles. We had to delay the treatment on a few occasions, and then eventually I reduced the dose of the medications as follows. Carfilzomib, I gave only 1 vial, which is 60 milligram. Lenalidomide 10 milligram. This was started in January 2021 after 7 cycles of proper full dose KRD. Still, the patient continued to have recurrent CMV reactivation, which needed treatment with valganciclovir, and some recurrent bacterial infections. And we started IVIG in March 2021. For the last 1 year since starting IVIG and managing him with 60 milligram carfilzomib plus lenalidomide 10 milligram, he has remained in remission, and he hasn't had any more hospital admissions or infections. So he's now 69-year-old. And this is the free light chain graph, which shows no evidence of increase. So as a summary, just to remind, I think with the given evidence, our first option in a lenalidomide sensitive patient in first relapse would be daratumumab Revlimid Dex, followed by carfilzomib Revlimid Dex. And in case of high-risk cytogenetics, the PI-based regimens is probably as good as the RD. This is a reminder I mentioned, and that's the end of my talk, and I'm happy to take questions either now or at the end of the session.
Thank you, Dr. Osman, for a great presentation. We can take a few questions. I think we can take the questions since you finished early. We can take the questions now. Okay, so the first question I have received, how would you select anti-myeloma agent for extramedullary relapse?
Okay, so extramedullary relapse, as we all know, is a high risk, difficult to treat group of patients. Now, we have the options of going for chemo-based treatment, and we like the VTD pace and so on. And we have enough newer agents which we should probably try before going into VTD pace. It all depends on the dynamics of the disease. For example, if it's very aggressive relapse, maybe you have to use chemotherapy to control it. But if it is just extramedullary, but it's not, we have time, I think I would use the newer agent combination. For example, I had a young patient who had disease in her colon. So it was biopsy proven to be plasma cells there. And she did respond to VRD chemotherapy. On subsequent assessments, the disease had gone away. And so we didn't have to use chemotherapy. But at the same time, we have had patients who have needed chemotherapy because the disease was so aggressive and progressing rapidly. We used chemotherapy to debulk and then moved on to the newer agent. So there is no correct answer, I think.
Thank you. Other question, is the cure of myeloma a possibility?
So I think we are going closer and closer to cure of myeloma. So we know of trials which are looking at MRD positivity and then the subsequent part of treatment based on whether the patient is MRD positive or not. So the 4-drug induction regimen in a newly diagnosed myeloma, there have been trials which looks at MRD assessment after each phase. So I think it is. I think we are getting very, very close. And for the time being, we can't say that there is cure for myeloma, but I think very close.
Thank you for the answer. The last question I have is, from your experience, how frequent is the GI side effects with carfilzomib?
Yes, so I have a few patients on carfilzomib, and they have had some degree of, not everyone. I think in the induction phase, I had probably 2 patients who had GI side effects, but like with any other medication, if you give drug holidays and drug reduction, I think, we can overcome this problem. Yeah, I mean, the cardiac toxicity is what we were all worried about, and we are still worried about. GI toxicities, it's not that common, but it is manageable. I haven't stopped anybody carfilzomib just because of GI toxicities.
Thank you, Dr. Osman, for the great talk. We will move now to the next, and it's my great pleasure to invite Dr. Amal Bihani to be the moderator of the session.
Thank you.
Thank you, Dr. Firas. Thank you, Dr. Binyam, for the great presentation. Our second satellite symposium is sponsored by Gilead Company, and it will be presented by Dr. Marwan Shaheen. It is about the role of liposomal amphoby in the treatment of invasive fungal infection in hematology setting. Dr. Marwan is a consultant hematologist and bone marrow transplant from King Faisal Specialist Hospital, Riyadh, and he is trained. He was trained in King Faisal initial fellowship, and then he went to Toronto at Princess Margaret Hospital, where he did hematology and bone marrow transplant training. He is in the lead group for leukemia. And Dr. Marwan, the floor is yours, please.
Thank you very much, Dr. Amal. Thank you for the SSBD and for Gilead to invite me to present. I want to remove, I think you can see the slideshow, yeah? I need to remove it. Yesterday we did the training and they told me that it will not show here.
Not projected.
Okay, let me try now again. Yeah, it was, but with the projector view, which I not want. I'll try now again, share. Okay, so
Yes.
Okay. I will remove the... So let me start till the slide is showing. So what we will do today, we will present the invasive fungal infection landscape, especially among our hematological malignancy and immunocompromise in general. This lecture is sponsored by Gilead, and they not recommend to use any product different than the manner in the prescribe information. Today I'll speak about the mold and the mold landscape, the Mucor Mycosis, Candida species, and the IDSA. So first, I'll start with the mold infection. So first, I'll speak about the primary risk factor for invasive pulmonary aspergillosis. And those patients for hematological malignancy, the main risk factor is the prolonged neutropenia. And in other, like for example, in critical ill ICU patient, the risk will be the long-term sickness and admission to ICU. We all know that the neutropenia duration for more than 17 days is carrying the high risk for invasive fungal infection, allogenic stem cell transplant with mismatch or with GVHD and AML MDS infection. Any neutropenia more than less than 7 days and autologous stem cell transplant will put your patient on a low risk, and anything in the middle will be intermediate risk. So if you go with a spectrum for all immunocompromised patients, you will see that the autoimmune disorder, the solid tumor, kidney transplant, and autologous stem cell transplant will put you on a lower risk than the HIV, multiple myeloma, other MDS, and chronic leukemia, for example, at heart transplant, and as I mentioned before, the high-risk patients. It's not only the risk factor, it's the comorbidity. For example, I'll highlight 4 comorbidities. The previous invasive fungal infection, if your patient comes, for example, for chemotherapy and he's known to have previous fungal infection, this really will increase his risk to develop another one. Uncontrolled diabetes mellitus or metabolic acidosis, patient with co-infection with CMV, and patient with chronic obstructive pulmonary disease. The other thing that, although we know that prolonged corticosteroid treatment create a bigger rule, but the also other agents, cytarabine and anti-TNF, the other dose of radiation play a role. If you allow me here, I will give an example. If you want to study the incidence of fungal infection on the hematological malignancy without transplant, you will find that majority of the acute leukemias carry mold problem. So always we think of mold infection in our population. And if you study further those mold infection, you will find that 90% is Aspergillus, and the other mold, non-Aspergillus mold, is increasing. You can see increase in many of the study, and I will show you that later. Among Candida, in our population, Candida still there, and Candida non-albicans is increasing also. If you focus on a transplant patient, you will find that Aspergillus molds only 60%. Other mold is more than 10%, which is really significant compared to previous years. Mucor now in a transplant setting reaching up to 7%, which is supposed to be very rare. The problem with the incident and with the mortality that you cannot compare country to country direct comparison, because the data presented is from multiple sources in each countries. But this will give you a hint. For example, also you have to look on the period that the study show this incident. For example, in Canada in 2008-2010, there was 8.9 incident of invasive aspergillosis with mortality around 30%. In France, it goes by 1.4 in 100,000 population. In Italy, it was more significant, for example, 6 per 1,000 admission in the hospital. So there is multiple way to check the incident and the mortality. If we go to our local data, here Dr. Denning reviewed the fungal burden in our area, and he compared this to France from 2 resources, the National Institute in France. And if you see here in Saudi Arabia, you can see that the invasive aspergillosis is 7.6 per 100,000, which is 6 times more than France and also in other Arab countries. This study, for example, was reviewing around 150,000 COPD patients in the period from 2009 and 2014. So in this 5 years, in 1,500 COPD patients admitted to the hospital, they found Aspergillus, invasive aspergillosis in 1,940 patients. And among those 2,000 in general, in those 5 years, there was only 200 patients with hematology and cancer patients. So the majority of patients was from COPD. And this should be kept in mind because some of our even immunocompromised patients have COPD or chronic lung problem. Another study which showed the same thing, Dr. Abdurrahman Rajhi from King Faisal Riyadh reviewed a chronic aspergillosis in a patient in paranasal sinus thrombosis, which showed 23 cases of those patients were cancer-free, HIV negative, normal WBC, and none of the patients had received immunosuppressive therapy. Majority, by the way, of the patients were from the southwest area, 15 patients out of the 23. In the azole resistant, also it's become a growing public health menace, threat. For example, in Netherlands, they reviewed about 100 cases from high-risk patients from ICU and hematology ward. And they found that 16.2% were resistant to voriconazole, Aspergillus fumigatus, resistant to voriconazole, and around 20% of those 100 patients were resistant to one of the 3 azole, voriconazole, posaconazole, and itraconazole. This is, of course, a big number. Also, there is a study from Asia, which include Iran, Kuwait, Pakistan, which give that the incident here of resistance of the triazoles is up to 11%. There is multiple mechanism of the azole resistant. Mainly, for the azole, it's the drug efflux pump. And in the echinokindin, the main resistant mechanism is the alteration of the target enzyme. But there is some species which is inherently treatment resistant. For example, the MIC of fluconazole and voriconazole for tropicalis are higher than the Candida albicans. And the crossi is intrinsically resistant to fluconazole. We know that. So also we know that the Candida parapsilosis is resistant to fluconazole and voriconazole. So the mechanism is becoming more and more for resistant. If we go to Mucor Mycosis, which is before previously known as zygomycosis, did you lost? I think you lost the slides.
Yes, we lost. Try to upload again.
I will again share it. Sure. Good that I have my mobile as a backup to see what you can see. Window here, share. Hopefully it will show now. Yes. So the Mucor Mycosis, which previously known as zygomycosis, it's a rare infection, but the incidence is increasing significantly. worldwide. In a 10-year French study, the incident increased, the decade or the 10 years incident increased from 0.7 case per year, or per million, to 1.2 case per million. And also in the transplant center, any transplant center is facing more of mucor mycosis than 10 years ago. The hematological malignancy are the most prevalent causes, but also other non-hematology malignancy, like for example, in our liver transplant, they faced 2 cases last year. One of them, they have to remove the eye that involved his eye. So it's really invasive, and the majority of them will be in the pulmonary, but it can also affect the sinuses. It can be disseminated in immunocompromised, and any soft tissue can be affected. Also, I want to remind you of those with corona associated, COVID associated, but the good news that it was mainly in India. I mean, not in our, not in all the trends, or the not in Omicron, for example. It's aggressive, like I mentioned. Again, also we want to see that the spectrum of the antifungal agent is important. So studying the susceptibility in your center is crucial. Unfortunately, most of our centers not have the manpower to go and look for the susceptibility. Here, this was done in 2015, and show you that, for example, the caspofungin, for example, which is commonly used as empiric, will not cover many of the mucor, fusarium, or the resistant, well-known resistant organisms. And even in Candida, some of the azole will not cover. So really you have to keep this in mind and choose the antifungal that will be more broader in your population, depend on how sick, how high risk is your patient. And early treatment is very important. Here an example of published data on 2011, which showed that the early initiated of the liposomal amphotericin in a patient with the halocine only can improve survival up to 82% on 12 weeks. And also, if you initiate only by CT finding alone, you can save 52% of the patient early, within 12 weeks here, but I mean as early as possible. So the Infectious Disease Summit or Society of America, IDSA, reviewed their guideline in 2016, where they updated the 2008 one, and still for empirical therapy with very strong data, the liposomal amphotericin and an echinocandin, either caspo or micafungin, still there. And after that, the voriconazole in empirical setting, with moderate only strength of evidence, and the pre-emptive therapy you can use also. In invasive pulmonary aspergillosis, the treatment still is the voriconazole and the liposomal amphotericin. In mucor mycosis, the risk to cure in an immunocompromised patient and with the intention to increase the survival is to immediately initiate liposomal amphotericin more than 5 milligram per kg. If there is no CNS involvement. With CNS involvement, there is some evidence that increasing the dose to 10 milligram per kg will help. And of course, I want to remind you that in those cases, please involve surgery, as debridement will be also important in therapy. What about Candida? In Candida, in hematology, as a hematology or hematologist, we not face a lot of Candida in our patient, but nowadays in ICU setting, and some of our patients will go to ICU, they saw that there is a trend in changing which organism in the candidemia. This is from 7 ICU setting, different setting, and this is studying only central line associated candidemia or bloodstream infection. And they found that in candidemia, the risk since 2004 or after 2004 the risk of candidemia is more than the Staphylococcus aureus, which is the previous majority of those line infection. So from 2004, there is a significant change. And this is also to show you that the candidemia, this is multiple global data, which showed that the distribution is different for the non-alpican. And you can see that glabrata and Aspergillosis is really increased in some of the country, for example, South Africa, Spain, USA, more non-alpican candidemia is noticed. If you go with the local data, Dr. Al-Uthman published this in 2017, burden of treatment pattern of invasive fungal infection in hospitalized patient in Middle East. Here, this is a real-world data from Saudi Arabia and Lebanon. In Saudi Arabia, they include King Saud University in Riyadh and King Abdulaziz Medical City in Jeddah. And they found that the alpican on those patients with invasive fungal infection is 56%. So the non-alpican is really increasing in our patients. And again, this is from Dr. Al-Musawi, King Fahd Hospital in Khubar, where he showed that in ICU setting, those patients with alpicans only 30%, and the non-alpican is really increasing. In Tropicalis here is 23%. This was published in 2021. If you also go and study the distribution for Candida spacing by antifungal, you can see here three pie charts. The left one with no antifungal prophylaxis at all, and the middle one with prophylaxis less than 7 days and from the time of culture. And the right-sided is the one more than 7 days, and most of the prophylaxis was with fluconazole in 70%. And you can see here that a type of prophylaxis or the prophylaxis given will alter the type of the candidemia. For example, for patients who receive more than 7 days, you can see the alpican become less, and the glabrata and the tropicalis crossi is mainly increased. So prophylaxis will alter the distribution. And another study with more numbers. This is 2,200 patients with prior exposure to prophylaxis. The type of prophylaxis here, they study before and after. So the candidemia after fluconazole, you can see that the albicans will decrease. And for Caspo, for example, the non-alpican will increase and will be the majority. The albicans after caspofungin prophylaxis only 20%. And among the breakthrough, which is also important in our patient population, breakthrough candidemia will be mainly non-alpican. This is to show you that the non-alpican in any breakthrough candidemia is more than the alpican candidemia. And also, if you study among those invasive candidas, if you study the prophylaxis, you can see that with using fluconazole, there will be more resistant because non-alpican is more, as I mentioned. Now, what about the survival in ICU? This is, again, data from 2,500 cases on patients with in France with ICU setting. And they found that among candidemia cause of death, the mortality was more from crossi, Candida crossi, and Candida kiefer in the green and the blue, and not, for example, Candida parapsilosis. This is from also Dr. Al-Musawi publication in Al-Khubar, where they found that the mortality mainly here from in those ICU cases from 2012 and 2018 were from non-alpican, crossi, and glabrata. The IDSA from recommendation for treatment for candidemia, initial therapy with indonafungin, caspofungin, or micafungin, and you can, in not sick patient, which is most of our patient is really sick, you can have some alternation, but echinocandin still the initial therapy for candidemia up to now. So my take-home message at the end is in hematology oncology patient, mold infection is more. In ICU setting, yeast, especially the non-albicans, is increasing. Early recognition of invasive fungal infection is very important to survival. Susceptibility testing is fundamental for better outcome. There is a change in the epidemiology of fungal landscape with the shift toward Candida non-albicans. Prophylaxis can change the epidemiology. Emergence of resistance in different antifungal class is really a threat, and we should continue the susceptibility studied. Delayed antifungal therapy can link to increase in mortality. Liposomal amphotericin is a broad spectrum in activity and with minimal acquired resistance in many of the species. Shift to an alternative antifungal as early as possible when resistance is suspected. Thank you very much, and I'm happy to receive any question.
Thank you, Marwan, for this elegant presentation. We have a few questions, and thanks being on time, so we can get some questions. So the first question is regarding the use of liposomal ampho-B in practice as a prophylaxis in high-risk patients who have some contraindication in using azoles, which is the standard of care that we are going with. So what's your practice in King Faisal, Riyadh?
So in those patients with really ultra high risk, in, for example, GVHD or in a transplant, allogenic stem cell transplant setting, when the azole is, for example, chemo or drug-drug interaction is there, we usually bypass this by echinocandin in a patient with not known before with invasive fungal infection. And if the patient really during the chemotherapy develop any invasive fungal infection, we do ambisome, amphotericin ambisome, especially if we suspect also atypical type of invasive molds like mucor or fusarium. And but we not use it in all our patients. So still our prophylaxis in high settings still is the azole and the caspofungin from the echinocandin in our center. But in selected patient, we go with amphotericin, liposomal amphotericin.
The second question I have is that what do you think about the role of combination in disseminated invasive? That is a common challenge between the ID and us. So what do you have in the guideline? Is there a role of any combination?
Now with the endemic with COVID, our colleague in infectious disease become really in agreement that in those patients we should really consider combination. So before, they keep asking about evidence, and it's very difficult to get a prospective study on those patients, either to give combination or no. So we try to push our infectious disease to get a combination, and nowadays better, our situation is better.
And the last question I have is that what diagnostic modalities you rely on in or you are following in the scheme for your tracing fungal infection in leukemia transplant patient? So do you do the baseline serology or following how you act on the CT scan? How frequent you will repeat those tests?
So we go by the serology regular in our patient who admitted for either chemotherapy or transplant. And we do this twice weekly on regular basis, Aspergillosis, galactomannan, and fungitil. With any fever, we tend to do low-dose CT instead of doing X-ray. But if it's like in the night or the weekend, usually they go by X-ray. But we not consider this initial. We wait 48 hours to 72 hours with a febrile neutropenia in order to push for, look for, fungal as a cause. And sometimes really when the patient is ultra high risk, we should do initial low dose CTA immediately. and call for possible bronchoalveolar lavage serology, which have more yield. So the galactomannan, the Aspergillus galactomannan yield from the BAL is around 60% compared to in the peripheral blood is less.
Thanks a lot, Marwan, for answering all the questions, and thank you, Gilead, for sponsoring this session. So we'll conclude this satellite, and we'll go to the next satellite talk, which is sponsored by Takeda, and will share with me the session Dr. Marai, and he will introduce the speaker, who is Dr. Fadl Shibani. Dr. Muhammad Marai is a consultant adult hematologist and bone marrow transplant from King Fahd Medical City. Dr. Marai is the director of bone marrow transplant and cellular therapy at King Fahd Medical City. He did his fellowship program, his residency and fellowship program in United States, and he has a special training in lymphoma. And he will introduce Dr. Fadl Shibani, who will go for the next talk about management of newly diagnosed a patient with lymphoma. Please, Dr. Marai. You are muted, Dr. Marai. So maybe Dr. Marai has some technical issues, so I will present Dr. Fadl Shibani. Dr. Fadl is a consultant hematologist and bone marrow transplant from King Faisal Specialist Hospital, Riyadh. He did his clinical fellowship in Cornwall Medical Center in New York, and he has his residency also in the United States, Virginia.
Assalamu alaikum.
Yes, Dr. Marai, you are with us.
Yeah, good afternoon. Sorry for that. We'll move to next presentation, going to be presented by Dr. Fadl Shibani, sponsored by Takeda, about newly diagnosed advanced Hodgkin's lymphoma, the management of newly diagnosed advanced Hodgkin's lymphoma. Dr. Shibani is a consultant hematology at King Faisal Specialist Hospital. He's graduated from King Saud University, and he joined internal medicine program at King Faisal Specialist Hospital, where he graduated, and then he joined Weill Cornell Medical Center, where he got his fellowship in adult hematology. He has specialist interest in lymphoma. He had multiple publications in well-respected journal. Dr. Shibani, the floor is yours. Thank you.
Thank you, Dr. Marai. Can you hear me now?
Yes, go ahead.
Okay, perfect. So my name is Fadl Shibani. I'm a consultant hematology at King Faisal. Thanks for the introduction, Dr. Marai. So we'll be talking today about the management of newly diagnosed untreated advanced stage Hodgkin lymphoma. So we'll start with a bit of a background. Hodgkin lymphoma, as you all know, it's characterized by the presence of Reed-Sternberg cells in the background of inflammatory cells. Reed-Sternberg cells has a classical marker, which is CD30 positivity, which is present of around 98% of patients with Hodgkin lymphoma. Hodgkin lymphoma, in terms of incidence, around 80,000 new cases diagnosed with Hodgkin lymphoma in 2018, making it one of the most common lymphoma diagnosed globally. Incidence in males is around 1 per 100,000, and in females is 0.8 per 100,000 population. Hodgkin lymphoma accounts for can cause significant mortalities. Around 15,000 males and around 10,000 females dies globally because of Hodgkin lymphoma. The incidence in Saudi Arabia is more or less the same. Hodgkin lymphoma is the 6th most common cancer diagnosed in 2015 as per the Saudi Cancer Registry. So when it comes to incidence, Hodgkin lymphoma has a bimodal age of distribution. So it initially occurs typically seen between patients age of 15 to 35, and then you have another peak in patients more than 65. However, I would like to point your attention to the dark arrow. So the dark arrow represents the mortality rate in patients with Hodgkin lymphoma, and as you advance in age, the risk is potentially more significantly higher in patients with advanced age. Patients more than 65 years of age account for nearly 70% of patients who die from Hodgkin lymphoma, which is quite significant. So we face special challenges when we're dealing with patients with Hodgkin lymphoma, whether they are young or they are elderly. With young, you want to give the best chemotherapy therapy option for them. You want to be aggressive, and you want to decrease the late onset toxicity, especially risk of malignancies, risk of secondary cancers, infertility, etc., and which we will come to it in a second. However, when we're talking about elderly patients, dealing with elderly patients carries its own challenges. For example, elderly, they more commonly present with advanced stage. They do have a presence of these symptoms. They do carry their own comorbidities, which really limits your options in treatment of Hodgkin lymphoma on those patients. They don't tolerate aggressive chemotherapies. Most commonly, when they relapse, they are really not fit to get an autologous stem cell transplant, and this is a challenge on its own. One of the most important prognostic factor for patients with Hodgkin lymphoma is the stage of at which the patient is diagnosed. So patients with advanced stage carries poorer prognosis than patients with limited stage disease. Around 40 to 50% of patients with newly diagnosed Hodgkin lymphoma actually falls into the advanced stage category, and the risk in developing countries is much more. Advanced stage typically is constitute stage 3 and stage 4 disease. Stage 3, as you know, both sides of the diaphragms are involved, lymph node groups on both sides of the diaphragm. Stage 4 more goes to extra lymphatic tissues. So there is really an unmet need in previously untreated stage 3 and 4 disease, and this is basically the focus of this talk. So if we look to the prognosis, to the 5-year survival of patients with Hodgkin lymphoma, as expectedly, patients with stage 1 and stage 2 disease, they do have a favorable outcome. Their 5 years overall survival is around like 92 to 93%, which is excellent for limited stage patients. However, as you advance in stage, patients with the stage 4 disease, they do carry a significant mortality. There is like a 20% decrease in number of patients surviving more than 5 years in stage 4 disease if you compare it to stage 1 disease, for example. If we translate this into more of a percentage-wise, out of 100 patients you treat with a limited stage Hodgkin lymphoma, around 10% of them will be refractory, will relapse to frontline ABVD treatment. However, with advanced stage Hodgkin lymphoma, if you're going to treat 100 patients, there is like a 30% chance of having a refractory or a patient relapsing after frontline ABVD treatment. Of course, patients who fail frontline treatment go on to receive a salvage therapy with a plan for autologous stem cell transplant. And autologous stem cell transplant carries in its own risk of substantial toxicity, namely bone marrow suppression, risk of recurrent admissions because of high-dose chemotherapy, cardiac toxicity, presence of secondary malignancies, infertility. And more commonly as well, quality of life. So patients who have either refractory disease or relapsed disease, they do have a higher risk of having anxiety disorder, depression, cognitive impairment, issues with their work and employment issues as well, and financial problems. Even if we put all of this aside, patients who fail frontline therapy, their chance of cure is around only 50% with the current salvage therapy and the autologous stem cell transplant. So in this trial, they looked into around 237 patients who failed frontline therapy and went on to receive salvage therapy followed by autologous stem cell transplant, and the 5 years overall survival of around 57%. So so if you have like 20 patients with a relapsed Hodgkin lymphoma, 10% will be salvaged with autologous stem cell transplant and 10 won't. Looking more into the prognosis of patients with Hodgkin lymphoma, so we mentioned that the stage of the patient is the most important prognostic indicator when it comes to Hodgkin lymphoma stratifications. The other is the International Prognostic Score. This was done by the International Prognostic Score Committee, a German committee, which looked basically into a couple of specific factors. They thought this may be contributing to the prognosis of the patients. They use univariate analysis, and then they came up with this IPS score, which involves the age of the patient, the male gender, the stage of the patient, serum albumin, hemoglobin, white blood cells, and lymphocyte count. And patients with a higher IPS score, they do have a worse prognosis than patients with a lower IPS score. This translates into a freedom from progression. So patients with a higher IPS score of 4 to 7, their 5 years freedom from progression is around 65%. Compare this to patients who have, for example, 0 or 1 or 2 IPS score, their 5 year survival of their 5 years freedom from progression is around 81%. I would have to say that we don't typically include IPS score in management of Hodgkin lymphoma. It's not part of, so we don't change the treatment based solely on IPS score. Other factors that can contribute to patients with Hodgkin lymphoma and that can affect their prognosis is age of the patients, serum albumin, male factor, presence of extranodal disease. So this is basically the algorithm for treatment of Hodgkin lymphoma. So what we do for patients with early stage disease, stage 1 and stage 2 favorable risk, we give them 2 to 4 cycles of ABVD followed by involved site radiation therapy. If they fall into the German favorable group, we typically give them 2 cycles of ABVD followed by 20 gray of radiation therapy. Patients with early stage unfavorable outcome, the most commonly used option is 4 cycles of ABVD followed by radiation therapy. I would say probably minority of patients, minority of centers will use either Stanford regimen or escalated BCOP. For advanced stage disease, again, the standard of care is 6 cycles of ABVD. Minority will use either Stanford regimen or escalated BCOP, plus minus radiation therapy. So ABVD has been the standard of care for treatments of Hodgkin lymphoma since 1975, and this is basically what put ABVD into the map of management of patients with Hodgkin lymphoma. And this trial, ABVD was compared to what used to be the standard of care for patients with Hodgkin lymphoma, which was the MOC regimen. It showed a similar efficacy and a better safety profile. However, even with ABVD, there is a 30% chance of being refractory to the treatment or relapsing following ABVD treatment. In an effort to improve on ABVD, the German, what they did, they did the HD9 trial in which they compared escalated BCOP to a standard BCOP to an ABVD based regimen. And the result of this trial showed an improvement in freedom from treatment failure in patients who received BCOP compared to ABVD. However, and even there was there is statistically significant overall survival, though it wasn't much, to be honest. In 10 years analysis, they confirmed that patients who received escalated BCOP had a significantly better freedom from treatment failure and overall survival than standard BCOP or ABVD-based regimen. However, BCOP by itself carries its own risk of long-term toxicity, risk of, for example, with this 10-year follow-up, risk of acute myeloid leukemia is around 3%, risk of secondary malignancies is much higher. ABVD and BCOP, they do have doxorubicin, they do have anthracycline in it, and anthracycline, as you all know, is notorious for causing cardiomyopathy. And the mere presence of cardiomyopathy in patients with Hodgkin lymphoma increases their morbidity and mortality. There is around 7.4% increase in coronary artery disease in patients who receive radiation therapy. And even in patients who did not receive radiation therapy, there was a significant increase in risk of death. BCOP as well is associated with a reduced ovarian reserve. Amenorrhea and infertility is high, both in males and in females who were treated with escalated BCOP. And keep in mind that majority of patients we see with Hodgkin lymphoma falls into the age group of 15 to 35 years of age. So it's really an intense treatment, and the treatment-related infertility is especially a concern for younger populations. ABVD by itself carries its own risk. So in addition to the notorious neuropathy caused by ABVD, bleomycin can actually induce pulmonary toxicity, and the percentage of patients who develop pulmonary toxicity secondary to bleomycin varies from different reports. So it ranges from a single digit to up to 25% of patients who receive ABVD develop pulmonary toxicity. The mere presence of bleomycin pulmonary toxicity impacts the overall survival of patients. So it does decrease the 5 years overall survival from 90% to around 63%. So in an effort to improve on ABVD, brentuximab, in addition to ABVD, was studied in patients with Hodgkin lymphoma. Initially, brentuximab showed a promise in patients with relapsed or refractory Hodgkin lymphoma, and it showed significant response. And this led to the initiation of Echelon-1 trial, which looked basically into patients with Hodgkin lymphoma, around 1,300 patients with newly diagnosed, untreated, or treatment-naive Hodgkin lymphoma. Mostly with stage 3 and 4 disease. I would have to pinpoint that the age of the patients included in this trial was above 18, and they did not have an upper limit. So in BCOP trial or escalated BCOP trial, the upper age limit was around 60. In this trial, there was no age upper limit. Patients were stratified into AAVD or brentuximab-based therapy compared to ABVD. All patients received 6 cycles, and they looked into a primary, their primary endpoint was modified progression-free survival. So if we look to the modified progression-free survival, ABD was superior to ABVD. The 2 years modified progression-free survival with the brentuximab-based therapy was around 82%, compared to around 77% of patients who received ABVD. So there was a statistically significant difference in favor of brentuximab-based therapy compared to ABVD. However, there has been some criticism to this article saying that you used modified PFS, which is not a clinically defined or well-established trial endpoint. So even if you use the routine or PFS, the routine progression-free survival, there is still superiority of brentuximab-based therapy over ABVD. So the PFS benefit was still in favor of patients who received brentuximab-based therapy compared to ABVD in a 3 years follow-up. Progression-free survival benefits was still in favor of brentuximab-based therapy compared to ABVD, with around 7.1 improvement in 3 years progression-free survival compared to ABVD. This translated into a 30% reduction on progression-free survival with the brentuximab-based therapy. And the benefit was observed in majority of the subgroup, mainly in patients less than 60 years of age. They derived this benefit. and most commonly in patients younger than 30, which we'll come to it in a second. You will still see the benefit in patients with an IPS score, with a higher IPS score, and patients with baseline B symptoms, and in the sex of the patients as well. So at the time of the initial publications, the overall survival data was immature. So there was a trend toward a better overall survival with a brentuximab-based therapy compared to ABVD. There was more death recorded in patients with ABVD, around 39 patients out of 670 patients, compared to patients who received brentuximab AVD, around 28 patients out of 664 patients. So, of course, if brentuximab-based therapy is more effective than ABVD, it translates into using of a lower salvage therapy, lower autologous stem cell transplant, and lower usage of immunotherapy in patients with a relapsed disease. So using a brentuximab-based therapy at the beginning of in patients with advanced untreated Hodgkin lymphoma result in around 30% fewer brentuximab patients, 33% fewer subsequent chemotherapy and subsequent transplantation as well. Most of the benefit was seen in patients with younger population and adolescent and young adults. So patients younger than 30 and younger than 40 derived most of the benefit here. And as you can, just for the sake of time, I'm just gonna skip through this. If we look to high-risk features, defining by the stage of the patients, by the presence of extranodal disease, by the presence of high IPS score, the use of brentuximab-based therapy was superior to ABVD, was statistically superior for stage 4 disease and for extranodal disease, and was more of numerically superiority, though did not reach statistical significance for IPS score. And as I mentioned, with IPS, we really don't include IPS score in algorithm or management stratification for patients with Hodgkin lymphoma. So when it comes to toxicity profile of brentuximab-based therapy compared to ABVD results in more pneumonitis, as you all know. With the brentuximab, you see more of a peripheral neuropathy, you see more of neutropenia and febrile neutropenia. And in here, the majority of patients who develop peripheral neuropathy with the brentuximab-based therapy had actually resolution of these symptoms. Around 67% of patients had resolution of these symptoms. I would like to pinpoint that when we use brentuximab-based therapy, we should be using G-CSF because it decreases the incidence of neutropenia from around 73% to around 35%, and it decreases as well the incidence of febrile neutropenia from 21 to 11%. So there was, because I do have like 2 minutes left in my talk, there has been a 5-year update with a Echelon trial that was published in Lancet. They looked into the 5 years outcome of patients who received the brentuximab-based therapy, and which was compared to patients who received ABVD, and it still continues to show progression-free survival at 5 years, around 82% compared to around 75%. The benefit was seen in patients who was either PIT2 positive or PIT2 negative, but I would have to say that PIT2 negativity was statistically superior, and brentuximab-based therapy showed a statistical superiority in patients with PIT2 negativity. In patients with PIT2 positivity, it's more of a numerical number, though it did not reach a statistical significance. Again, incidence of peripheral neuropathy resolution and improvement in patients who received the brentuximab-based therapy. Around 84% of patients had improvement in their in their incidence of peripheral neuropathy. 71% had complete resolution of their peripheral neuropathy. Around 13% of patients had partial improvement in their peripheral neuropathy. So risk of secondary malignancies occurred in around 48 patients, 19 patients who received the brentuximab arm, and in around 29 patients who received ABVD in ABVD arm. So in conclusion, basically Hodgkin lymphoma is a disease characterized by presence of CD30 positivity. ABVD has been the standard of care for a very long time for patients with advanced stage Hodgkin lymphoma. Brentuximab based therapy is becoming more and more used now in patients with advanced stage Hodgkin lymphoma. And I would be more than happy, just for the sake of time, I'm just going to conclude, and I'll be more than happy to answer questions.
Thank you very much, Dr. Shaybani, for excellent and informative presentation. So we'll see if we have any questions from the audience.
If you can allow me, can I ask a question? How much, Dr. Fadl, you are adapting the bit-adapted therapy in treating patients with Hodgkin, whether escalation or de-escalation in your center?
So, so for advanced stage, basically, you're talking about limited stage or advanced stage?
For limited stage.
Okay, for limited stage, so basically the German trial, which was done in favorable patients, they did not mandate to get a PET scan after 2 cycles. But however, at the time that this trial was conducted, probably the use of PET scan was not as widespread as we see it right now. So we typically give patients 2 cycles of ABVD, get a PET scan. If they are in remission, we send them for radiation therapy. For advanced stage, it's more of a prognostic indicator. So if you're using a brentuximab ABD and you get a PET2 positivity after 2 cycles, if the patient is showing response, you will continue with the brentuximab based therapy. We don't escalate to BCOP because honestly, the risk of malignancy is high in those patients. With the 10 years follow-up of patients who receive escalated BCOP, the risk of AML is around 3%. And this more or less equates to the difference or the benefit that was seen in patients who received BCOP in comparison to patients who received Hodgkin or received ABVD. So in the original trial, PET2 positivity were randomized to either BCOP or ABVD. BCOP was associated with the 3 years with around the 3% improvement in their overall survival. But this is more or less similar to the risk of AML that you can see with these agents. And the risk of AMLs continues to increase with time. And especially with our population, the risk of infertility is high with escalated BCOP, so we don't typically use BCOP. And actually, even in the US, very few centers uses escalated BCOP.
Okay, excellent. So what salvage do you use, Dr. Shaybani, if you use like brentuximab upfront in advance in case of relapse?
So, so the standard use of brentuximab in patients with a relapsed Hodgkin lymphoma has not been shown to carry an overall survival benefit. There has been actually in the last ASH a trial that really questioned the use of brentuximab in addition to salvage therapies in patients with relapsed Hodgkin lymphoma. In patients, if we use the brentuximab based therapy for a frontline patients and that patient relapsed, we typically go with ESHAP, and if they goes into remission, then we use we go on to receive autologous stem cell transplant.
Excellent. I'm not sure if there are any questions from the audience.
If you allow me, just one more question. If you start with the brentuximab ABD, what your salvage usually be in case patient did not respond?
We use ESHAP. Typically, we use ESHAP. Yes, we use ESHAP. Though there has been many phase 2 trials, very encouraging result of For example, the use of brentuximab bendamustine, but that's basically in brentuximab naive patients, using of brentuximab nivolumab, but still it's randomized trials are ongoing, and until we get these randomized result of these randomized trials, the standard is that we use in King Faisal is Isha.
But are you adopting that despite the cost for high grade or high risk Hodgkin lymphoma to start with the brentuximab ABD?
So, the cost is a real issue, and it's had been an ongoing talk with the pharmacy and with the hospital because of the high number of patients. We use it sometimes in patients with a very high risk, let's say external nodal disease, advanced stage 4 disease. We use the brentuximab ABD, but in other patients who we feel like they probably, or like, for example, elderly patients more than 60, because the Echelon trial did not show superiority of brentuximab over ABBD in patients older than 60. We sometimes use ABBD. So the cost is an issue basically, and it's an ongoing discussion with the pharmacy.
Thank you.
I think we're going to conclude this session. Thank you, Dr. Shaybani, for excellent presentation. So I think we're going to have a break, and then we'll kind of continue section number 2. Thank you, everybody.
If you allow me just to announce, we will have 10 minutes break, and we'll be back to the second part of the satellite symposium, which is the leukemia satellite talk. And we have ongoing now a parallel session about the hematology task force. You can access it through the workshop. Thank you, and we'll go for a break for 10 minutes. See you at 2:50 exactly, inshallah.
Just wait for my confirmation.
Okay.
I'll start.
Doctor,
Shall I start
Dr.
sharing now?
Yes, you can. You can start sharing.
Okay. Can you
The
see
floor
it?
is yours.
We are online. Let us know, please.
Doctor, we're live. The floor is yours.
Okay. Thank you. It's my pleasure to be here. I'd like initially to thank the organizing committee, Dr. Amal Bihaya, Dr. Firas Al-Farih, for inviting me to be a moderator for this session. And it's my pleasure to be to introduce the first speaker, Dr. Prof. Muhammad Mahdi. He is a professor of hematology and head of hematology and cellular therapy in the Department of St. Anto's Hospital. And he is Professor Mahdi has a medical degree from university in London. He has a PhD. Also, he has Dr. Mahdi is well-known expert in myeloma as well as transplant. Dr. Mahdi is going to present plasmacytoid dendritic neoplasm, diagnosed and treatment approach over the time, and what's new. Prof. Mahdi, the floor is for you.
Thank you very much, Dr. Bakar. Assalamu alaikum wa rahmatullah. It is really my great pleasure and big honor to be with you today. Of course, I would have preferred to be in person, but inshallah, we will meet all together and enjoy the live interactions. So today I have been asked to speak to you, to give you a few data about BPDCN, which is blastic plasmacytoid dendritic cell neoplasm. You heard in this beautiful, fantastic meeting, I just heard there are several thousands of participants. Very impressive. Congratulations. You heard about rather frequent diseases. We earlier in the session, we heard about Hodgkin, which I think all hematologists have seen. We heard about fungal infections, which is something very frequent. But I can tell you, BPDCN is another story. In a country like France with 65 million people, you have 30 cases per year. So you would imagine how rare and how complex is the management of this disease. But I will tell you later that now we have an approved drug and there is a lot of hope. These are my disclosures. Why I'm interested in BPDCN? Well, it's a long story because 24 or 25 years ago, while nobody was interested on this, I did my PhD in immunology about these dendritic cells, and we published this in Blood in 2001. So, and this remains very close to my heart. So it's a very aggressive hematologic malignancy. If you look to the primary site, we used to call it PDC leukemia, but actually you have in 90% of the cases skin infiltration. You can see the photo, bone marrow infiltration, of course, lymph nodes, so it's like a lymphoma, CNS is quite frequent, and all other organs. And the diagnosis has been always very difficult because with skin lesions, the patient go and sees a dermatologist, and the dermatologist try to do their best. With lymph nodes, then you have the lymphoma doctors, and you think we're talking about lymphoma. If you have any organ localization, you may think about a cancer of whatever organ. Because the diagnosis is quite sophisticated and you need actually to have a combination of different markers. And I always say in my talks, think 1, 2, 3, 4, 5, 6. What does that mean? It means that these blastic cells express very high expression of CD123. They express simultaneously CD4, CD56. This is why it is 1, 2, 3, 4, 5, 6. So here it's a message for our colleagues from the lab that really they should think about this. There are also other markers, BDCA2, BDCA4. So the more, you get to markers and it becomes sophisticated, but you can identify these patients. There are also more and more frequent genetic abnormalities if you do NGS like TET2, ASXL1, very bad genetic. So I told you the epidemiology is unknown because it is very rare. Also, the semantic, the name of the disease has been changing over time. If you look to the WHO, 2008, 2016, we consider that this is roughly 0.44%, not 1%, but less than 1% of all hematologic malignancies. And in the US, for instance, in US 300 million people, in 2018, there were 219 cases. So you would guess that in the Kingdom of Saudi Arabia, if you have 30 million people, you would have maybe 20 or 22 cases. The outcome is horrible. You can see the survival of these patients. At 2 years, it's almost zero. You can achieve CR maybe in 40 to 50% of the cases, but they are usually elderly. You have a high early death rate, and they relapse very quickly. So they achieve CR now, and 1 month later, actually, they will relapse. And when it comes to the historical treatments over time, I think everything has been used in chemotherapy. The ALL chemo, I'll go back to this, the AML, the lymphoma, hypomethylating agent, but recently a specific drug. So let me walk you through the chemotherapy first. In the fit and young patient, but remember, the median age is 70. So usually they are not fit and they are not young for the majority. The ALL-based approach have been used, hyper-CVAD, recently venetoclax plus hyper-CVAD, alternating methotrexate Ara-C. Results are disappointing. Some teams, even in my own team, we have in the team 25 physicians, 10 of them do leukemia, leukemia doctors, experts, supposed, and we do the multidisciplinary meeting. You have members of the team, they say, oh, we'll do an ALL regimen, and the other members will do an AML regimen. And indeed, 3+7 has been used, and all kind of AML treatments if you are fit and young. In the old and unfit, who are the majority, because these patients have a very poor performance status when they come, people have tried the lymphoma regimens like SHOP, but usually it has been disappointing. More recently, azacitidine, decitabine, but again, nothing convincing. The only curative treatment for these patients is actually hematopoietic stem cell transplantation, allogenic stem cell transplantation. And if you want to perform allogenic stem cell transplantation in these patients, you need to achieve CR1. But the problem, if you want to achieve CR1, if you need high-dose chemotherapy, the patients are old and usually unfit. They cannot tolerate very well the chemotherapy. Also, you need to be very quick because you can achieve CR now, but in 1 month, they will relapse very quickly. Rate of kinetics of relapse is very quick. So, and you're not ready yet for your transplant because it takes a few weeks to prepare the transplant. And this is where I think now we are fortunate to have a new targeted agent. It's a little bit difficult to pronounce tagraxofusp. So we usually call it TAG. So I will call it TAG because otherwise it's a bit complicated to pronounce. It's a novel targeted therapy directed against CD123 because CD123 is the IR receptor alpha, and it is highly overexpressed in BPDCN. So it's a very specific targeted therapy, and there is in vitro but also in vivo data showing that it works very well. And this is why it has been already approved by FDA, but also by EMA. I don't know exactly the situation in the kingdom and in the Gulf exactly, but it is approved now and we can use it. And this is thanks to this study published in the New England Journal of Medicine. So New England Journal of Medicine, you would guess something very unique. 3 years ago by Naveen Pemaraju from the MD Anderson. So actually, they took patient with BPDCN. At the end, it was 47 patients. So 47 patients, but you go to the New England. So you would imagine the revolution this represents. And actually, they took either patient with BPDCN in frontline or also even in relapse. And this is very important to have in mind. And of course, the protocol has some other criteria. You can see here, for instance, the distribution, the demographics. 32 patients actually were treated frontline. 15 patients were treated after previous treatment. So you can see the median age is 70. They treated patient up to age 84 because the treatment is rather well tolerated. If you look to the manifestation, the clinic, exactly what I told you, 94% of the cases you have skin localization, 17% peripheral blood, 51% infiltration of the bone marrow, and 45% in the lymph nodes. So a mixture of leukemia, lymphoma, cutaneous localization, making it a little bit so that the patient can go through different pathways when they go to the health system, and they come with really very bad status. And in the 15 patients who were treated with previous lines, you have 9 patients who received 1 line, 4 patients 2 to 4 lines, and 2 patients more than 4 lines. And the results are really amazing because you can see here, for instance, the probability of overall survival, 50%. Remember, I'll go back quickly to my historical slide. You can see it here, 0%. And now we are talking, you can see, about 50%. And there are now ongoing. And the best result, of course, are in those patients who were able even to proceed to an allotransplant because you can bridge them to an allotransplant. And this is from the paper I copied and pasted. This is a 70-year-old lady, and you can see the infiltration. So it's very difficult, you know, because there's nothing specific with this. You need a biopsy, and you need to do the right markers on the biopsy. But when you receive the TAG drug, tagroxofosp, look at the results 3 weeks after the treatment. Everything has been cleaned because this is the power of targeted therapy. What about the safety? What about the safety? Actually, the safety and tolerance is really very good. You can see the usual, I would say, things we know in hematology, nausea, fever, fatigue, thrombocytopenia. I would like to draw your attention something quite specific, which is the capillary leak syndrome. And this is why you have a weight increased. And because it can happen with all of these kind of targeted antibodies, you know. And here, I think it's mainly in cycle 1, because of course you need to give several cycles, and it is manageable with supportive care. And I think we hematologists we are quite familiar with the capillary leak syndrome. It's not new for us. Remember, the old story with GCSF. And of course, after allogenic stem cell transplantation, we see from time to time capillary leak syndrome. And of course, you can monitor these patients for, weight increase, for edema, also hypoalbuminemia. So you need to monitor the albumin level. And this is relatively straightforward. And the drug comes with some specific recommendations, of course, how to manage all this. So when you look to these data from the tagraxofosp story and trials, 90% response rate, majority of responses, and this is important, are CR or CRC, and that is really the pathway, the bridge to a curative allotransplant if they have a donor. And actually, 45% of the patients, so almost half of them, although I told you the majority are old, they were able to be bridged to an allotransplant. So now, as I mentioned, since December 2018 and since last year in Europe, the drug is approved now for frontline treatment, but also in the relapse refractory from age 2 to up. But I told you they are mainly ordered. And this is really the first targeted therapy. And it's the first in class targeting CD123. But I think people, I'm sure, are familiar with the fact that CD123 is also expressed in many other diseases, many other leukemias. And of course, the drug is being investigated now in many other leukemias. But I think the story of how to target CD123, how to cure BPDCN, and you may say, well, if I have only 40 or 30 or 20 cases per year, should we invest on this? But this is the strength and the beauty of working on these very rare diseases and develop, because this is where you can create revolutions, I would say, in medicine and pave the way for other improvement. And we owe this to these patients, because if you have an orphan disease like this, an ultra-orphan disease like this, it doesn't mean we should let you down. It's our responsibility towards the patient. So now there is lots of development. CAR T cells are being developed. There are other monoclonal antibodies, but now there are some bispecific antibodies. So you will see the future is really bright. The other development in this field is about also targeting BCL2, because there is an overexpression of BCL2, and there are now discussions about venetoclax, navitoclax, etc. But for the sake of time, I will not be able to discuss all this. But again, what I wanted to highlight, and that was the cover from Nature Biotechnology 2019 issue, where they highlighted this revolution of the first CD123 targeted drug approved in such a rare cancer, namely the blastic plasmacytoid dendritic cell neoplasm. So with this, I'd like to thank you all for your attention, and I deliberately wanted to save a few minutes for the question, because I think this is a rare disease and we need to spend some time discussing this entity. Thank you very much. So I'm more than happy to take questions, but I can't see our moderators. Can see now Dr. Al-Bihani joining.
Yes, Doctor. Thanks for elegant presentation. It's supposed to be Dr. Bakkar is following the presentation, and he should moderate. I think he has some connection problem.
I see this.
Yes, thank you. So I did not see any question. Apparently, it's a rare disease, and there are a lot of things coming on the pipeline for the management of such rare disease. But I mean, do you think that we have to always, I mean, go on the direction of clinical trials and investigation, or working or managing such a rare cases?
I think your comment is very nice. The problem with such a very rare disease is that it's very, very difficult to do clinical trials. So I think the challenge we are facing in this disease is that we need to find the cases, because I can assure you, even when you do everything to look for them, you can miss them because of the very heterogeneity of the disease. So this is why I think the key message for the community, for our lab technician, for our lab physicians, for the hematologist, for the general practitioner, for all the colleagues in oncology, the lymphoma doctors, the leukemia, is to think about it in front of a patient who is in a bad general status, coming with his skin lesions all the time, more than 95%, having maybe lymph nodes, but also having blasts, is to think that this is not lymphoma with skin localization. This is not leukemia with skin localization, but this is an entity by itself, because you have the right treatment for it. Because of course you can tell me why trying to find it if we can't do anything about it. But here you have a targeted therapy. So for me, the diagnosis is crucial to be made. And this is why what we need is to do is awareness, to really educate the colleagues, the community, and everywhere spread the word how to identify these patients. Because when you identify them, you can give them the right drug, and then you can achieve CR. You can bridge them to transplant, or you can continue treatment. So there are different scenarios, but then you can cure them, because otherwise, I showed you, their prognosis is 0% survival. So I think it is really crucial for me, having a rare disease, an ultra rare disease, gives you more responsibility to find it and to try to do the right treatment.
I agree with you. How much it is confused with the mycosis fungoides or peripheral T-cell lymphoma in the referral? It's not like that when you saw them.
Very, very good remark, Dr. Al-Bihani. Most of the time, the patient will spend several months with the dermatologist, because even when you do the biopsy, if you don't do the right markers, you may miss it, and you may. But originally, and I understand, my wife is a dermatologist, so I'm quite, and my sister also, so I'm a bit familiar with the behavior. I mean, if everyone going to a dermatologist with some skin lesion, the dermatologist will never think about, leukemia or BPDCN. But the problem we face is that they keep on having these lesions. This is why we need to educate about it, and we need to have like the interactions with the dermatologists and the general physicians, practitioners about that. Well, after 1 month, if the lesion is still there is maybe something wrong. You need to do a biopsy. You cannot just continue giving this cream or whatever.
Well, thanks a lot. At least there are targeted therapy which can tackle this rare disease. So hopefully our pathologists will work hard in establishing those difficult cases in diagnosis. Thank you, Dr.
Yeah, I'm sure, and I'm confident because I know most of the colleagues in the Kingdom and in the Gulf in general. And it's about just thinking about it, and it's just about putting the right markers, because there's nothing sophisticated about it. It's just that you need to put together when you do your flow cytometry or immunohistochemistry, CD123, CD4, and CD56. The 1, 2, 3, 4, 5, 6. And recommendation would be to say, why don't we include this systematically in all our evaluation? Because it's not an issue of cost. This is really very cheap. Everybody knows how to do it. It's just about thinking about it, because then you have the drug which is approved for these patients, tagraxofos. So it's a pity. It's like someone is telling me, we have CML, but we miss it, while we know that you can give imatinib, and we're not looking for translocation 922, but everybody will look now for translocation 922, and CML is very rare disease. Yeah.
So does PET could help in diagnosing such disease, or this is just
very good question. So usually I don't think the PET scan can allow you to make the diagnosis, but as I mentioned, 50% of the cases, they have lymph nodes in big lymph nodes, adenopathies, and of course the PET scan will allow you to detect them, and of course it allows to follow the response to treatment, because if you repeat, my concern is that we need to be careful not to push the patient, when thinking PET scan for the diagnosis, to put them in the lymphoma pathway, because then you start thinking lymphoma and you start treating like lymphoma, and the results are very, very, very poor and suboptimal with the lymphoma treatment. So yes, you can do PET, and usually most of the cases when you see the lymph nodes, people will do PET, but it doesn't allow you the diagnosis. The diagnosis is about the biopsy and the flow cytometry and the markers.
Thanks a lot, Dr. Mahdi, for answering all the questions. And by that, we will conclude the session, and we'll move to the next. Nice having you with us. Just be with us in the whole conference. We will be happy. So I will move to the next. شكرا يعطيك العافية دكتور. Move to the next satellite talk, which will be about by Astellas, and it's about relapse refractory AML with FLT3 mutation. And the speaker with us is Dr. Ali Al-Ahmari, Dr. Badr Ali Al-Ahmari. Dr. Badr is a consultant hematologist at the Adult and Stem Cell Transplant and Cellular Therapy in the Department of Oncology at King Abdullah Specialized Children's Hospital. Dr. Ahmari his residency in the internal medicine at King Abdulaziz Medical City, and then he did his fellowship in hematology and oncology in Washington University School and St. Louis in the state, and he did a fellowship in bone transplant in Washington University School of Medicine, again in the state. So Dr. Badr, the floor is yours, please.
Assalamu alaikum wa rahmatullah. Thank you, Dr. Amal, for the introduction. Today, I'll talk to regarding the topic of management of relapse refractory FLT3 AML. Trying to advance the slide. Okay. This symposium is sponsored by Astela Pharma to share experience and discussion about the management of relapse refractory FLT3 AML. According to the data from Saudi Cancer Registry in 2016, there was a diagnosis of 127 patients of acute myeloid leukemia. Probably this number is underestimated actually, and this number expected to be even higher these days based on the expansion in the population, indicating the importance of this disorder. Current integration of molecular profiling into AML diagnosis has helped a lot in risk stratification, better stratification of AML disease, and also finding therapeutic drug targets, and also as well as minimal or measurable residual disease monitoring for those patients. When it comes to the mutational analysis for acute myeloid leukemia, FLT3 mutation is the most common mutation in adult AML patients, and accounting for more than a third of those patients. There are two major types of FLT3 mutation: FLT3 ITD, which is the most common mutation, and followed by FLT3 TKD in the tyrosine kinase domain. And of course, this mutation has been implicated significantly to the outcome of acute myeloid leukemia, and it has been incorporated into the cytogenetic and molecular risk stratification of acute myeloid leukemia, associated with an overall poor prognosis affecting the long-term survival of acute myeloid leukemia. Probably it is likely the FLT3 ITD more affecting the outcome more than the TKD mutation. And there are several factors that can influence the prognosis of the FLT3 ITD, including the mutant allele to wild-type allele ratio, insertion site, and the length of the internal tandem duplication, as well as association with other karyotype and the presence or absence of NPM1 mutation as well. The FLT3 receptor has a major role in survival signal to the hematopoietic progenitor cells, and the presence of the FLT3 mutation can lead to constitutive activation of the FLT3 that lead to promotion of the proliferation of the blast cells and block the differentiation. As I said, there are two types of FLT3 mutation, either ITT, internal tandem duplication, which involving the juxtamembrane domain, or the TKD mutation, which is the tyrosine kinase, it's a point mutation in the tyrosine kinase domain. There are several FLT3 inhibitors available, some of them approved and some of them under investigation. Type 1 inhibitors, they're mainly targeting both ITD and TKD. Type 2 inhibitors, such as sorafenib, targeting type 2, targeting only ITD. In the upfront setting, the only FLT3 inhibitor approved is the midostaurin, and this is based on the RATIFY study when it's combined with 7+3 showed actually improvement in overall survival versus 7+3 placebo, and this has led to the approval of this medication in the upfront setting for FLT3 acute myeloid leukemia, either ITD or TKD. However, there are ongoing studies that trying to improve over the midostaurin by doing a different type of inhibitors, FLT3 inhibitors in this setting with a combination of chemotherapy. In relapse refractory setting, FLT3 mutation carry a very poor outcome with a median overall survival of less than 10 to 6 months. And we know that in relapse AML, around 20% of patients either acquired, they lost actually their FLT3 mutation or acquired FLT3 mutation. Overall, as I said, FLT3 mutation associated with low probability to achieve second CR with the standard intensive therapy, and continue to have dismal outcome even after allogenic stem cell transplant. There are certain different mechanisms of resistance to FLT3 inhibitors that usually lead to relapse post use of those inhibitors. There are extrinsic factors such as the drug-drug interaction that lower the level of the drug, maintaining the appropriate level of the drug in the circulation. And there are intrinsic factors that is associated with the development of other genetic mutation that can lead to activation of different pathway, including the RAS or MAP kinase pathways. There are certain mutations that has been associated with the use of type 2 FLT3 inhibitor, and there are certain mutations with type 1 FLT3 inhibitor. For example, this elegant work by Dr. Ahmed Al-Ataibi showed that frequent mutation in the FLT3 TKD has been observed following the use of type 1 FLT3 inhibitor. And this is clearly, as you can see in the right side, associated with a worsening outcome. Similarly, in the type 1 FLT3 inhibitor, there are frequent genetic mutations in the RAS MAP kinase pathway, including the NRAS, KRAS, which is also negatively impacting the overall survival. Different FLT3 inhibitor has been tested in the relapse refractory setting. Some of them actually did not show any significant improvement as a single agent, and some of them, they as a single agent showed an active effect on the relapse AML, especially when we talk about next generation FLT3 inhibitors, and we will talk about a few of them. First, we'll talk about the use of quizartinib. This is the data from quizartinib Quantum R, which is a randomized study for relapse refractory AML using quizartinib as a single agent versus salvage chemotherapy for those more than 18 years of old for relapse refractory AML patients. And this was for patients with FLT3 ITD mutation. The primary endpoint was overall survival. Secondary endpoint was event-free survival. Quizartinib was also allowed to be continued after allogeneic stem cell transplant. The study met its primary endpoint by improving the overall survival. In quizartinib, the median overall survival was 6.2%. In salvage therapy group patient, the overall survival was 4.7%. However, there was some increase in the toxicity, especially cardiac toxicity, with the use of quizartinib, and this did not lead to the approval of the medication in the United States. However, this medication is approved in Japan. The second agent is gilteritinib, which is a new oral and potent, highly selective FLT3 inhibitor, which as a single agent in a phase 1/2 study showed a composite CR rate of around 41% of patients. And this led to the initiation of the Admiral study to investigate the benefits of gilteritinib. This is a multi-center randomized trial compare gilteritinib with conventional salvage chemotherapy. The key eligibility criteria was adult patient with AML refractory or relapse after first line therapy. They allow patient who relapse post stem cell transplant, patient with FLT3 ITD and TKD patient were allowed as well. And the stratified patient based on the response to first line therapy, more than 6 months or less than 6 months, and also to be selected according to pre-selected chemotherapy, either high versus low intensity. High intensity regimen consists of 1 to 2 cycles of MIC or FLAG-IDA. Low intensity regimen consists of low dose cytarabine or azacitidine. Patient was randomized 2-to-1 into gilteritinib versus salvage therapy. Then patient can go into stem cell transplant, and patient in the gilteritinib group can resume the gilteritinib, and crossover was not allowed in this study. Primary endpoint was actually was a co-primary endpoint was overall survival and the CR/CRh rates. This shows you how much they screened. They screened around 625 patients, and 371 relapse refractory AML patients found to have FLT3 mutation, and they were randomized 2-to-1, as we mentioned earlier. Around 109 patients in the placebo and the control arm received the dedicated therapy. In the experimental arm, 246 patients received gilteritinib. In the gilteritinib group, 63 patients went on into stem cell transplant, while 19 patients went into stem cell transplant in the salvage group. In terms of baseline characteristics, were similar between both groups, with a median age for all cohorts around 62 years. And most of patients were intermediate, and this is expected according to the associated with normal karyotype with FLT3 mutation. Only around 12% of patients actually they receive previous FLT3 inhibitor, which is something we don't see it nowadays with the approval of the first line of use of FLT3 inhibitor. Around 1/3 of patients, or more than 1/3 of patients, they were actually primary refractory AML without previous allogeneic transplant. 2/3 of patients in both arms they were pre-assigned to high-intensity chemotherapy. Majority of the FLT3 mutation were actually FLT3 ITD, and less than 10% were FLT3 TKD. The study met its primary endpoint, where gilteritinib showed significant improvement in overall survival, with a median of 9.3 months versus salvage therapy, which was 5.6 months, 5 months, 0.6. 12-month overall survival was 37% in gilteritinib group and 70% in the salvage chemotherapy group. This maintenance in the improvement in overall survival was also maintained even after censoring for those who went into stem cell transplant. And in a post-hoc analysis, patients who received gilteritinib post-stem cell transplant, they showed improvement in median overall survival, 16 months versus 8 months. for those who did not receive maintenance gilteritinib. Regarding the co-primary endpoint, the CR/CRh rates, it was 34 in the gilteritinib group versus 15% in the salvage group. The improvement in overall survival was maintained across multiple subgroup, including, for example, it was maintained within those who have ITD and TKD groups. Also was maintained in those who has previous FLT3 inhibitor exposure, although the number looks much better for those who were not exposed previously to FLT3 inhibitors, as well as across those with cytogenetic abnormalities. In terms of those who receive chemotherapy and transplant, the median overall survival were longer for those who were assigned to high-intensity chemotherapy, as well as in the low-intensity chemotherapy. Also, patients who had received prior hematopoietic stem cell transplant, they have longer median overall survival for those who went into gilteritinib arm, as well as a higher level of CR rate in this subgroup analysis. What interested co-mutation analysis was also associated with improvement in overall survival. We know that FLT3 co-mutation with DNMT3 and NPM1, they has the worst overall survival. However, what's appear here in the analysis that co-mutation with DNMT3 and NPM1, they have much better overall survival when it's compared in the gilteritinib group when it's compared with those who have salvage chemotherapy. However, you cannot exclude the player of other covariates associated with this co-mutations. In terms of safety outcome, there was overall a lower rate of exposure-adjusted grade 3 and above adverse event. It was 19.4% per patient year in gilteritinib group versus 42.4% in patient year and patient went into salvage chemotherapy. The most common serious adverse events observed were febrile neutropenia and transaminitis. And the most common adverse event led to discontinuation of gilteritinib were high AST and ALT, as well as pneumonia. QT prolongation were also observed after the use of gilteritinib. There were 170 patient death in the gilteritinib group versus 81 in the salvage group, about a similar percentage. However, the mortality in the day 30 and day 60 were lower in the gilteritinib group compared to salvage chemotherapy. The most common cause for fatal adverse event in the gilteritinib group were pneumonia, large intestinal perforation, and septic shock, which is, although it's lower rate, but it's concerning. This is an abstract presentation in the last ASH, which showed that it's a COMORD trial, which is a randomized multicenter open-label trial in Asia, they replicated the Admiral gilteritinib study, and you can see from the curve here, they showed a similar improvement in the overall survival and composite CR rate. This trial further validates and affirmed the clinical efficacy and safety data on the Admiral trial. This scheme showed how to dose the gilteritinib and how to monitor the ECG and during this therapy. In the trial, those who did not achieve CR after the first cycle, they actually increased the dose from up to 200. Also, this is how to dose adjust the medication based on the toxicity developed through the treatment, especially the QT prolongation. The treatment must be interrupted and restarted once the adverse event resolved. In conclusion, FLT3 ITD is associated with poor prognosis, with low probability of achieving second CR, and currently there are only one FLT3 inhibitor that is approved for the treatment of the relapsed refractory FLT3 AML, which is gilteritinib. However, there are few unanswered questions in the use of FLT3 in the relapse refractory setting, including the benefit of switching from one inhibitor to another. What is the best combination with FLT3 inhibitor, the use of novel therapies such as venetoclax and others, and the role also of immunotherapeutic approach, including monoclonal antibodies, checkpoint inhibitors, CAR T-cell, and so on. So the area is still open for research. And with that, I conclude, and happy to take any questions. Thank you so much.
Thank you, Badr, for this comprehensive presentation about acute myeloid leukemia with FLT3 inhibitor. I am just, is there any questions from the audience?
Yes, if you allow me, there is a question. Thanks, Dr. Badr, for the excellent elaboration. We have one question about, is there any trial for upfront use of gilteritinib for acute myeloid leukemia patients?
Yeah, so there is ongoing study now, the HOVON trial, where the it's basically 7+3 combined with gilteritinib versus midostaurin, which is the standard of care. And the study is active in accruing patients, and I think the result will be coming in the next few years. Probably, I think there are other studies in elderly population that they are not fit for intensive chemotherapy. In combination with hypomethylating agents.
There is a second question. Is there any, what do you think about the gilteritinib for dual inhibition? Will it come over the resistance of FLT3 inhibition?
As I mentioned, it's a type 1 inhibitor that can inhibit both ITD and TKD, but the data that I presented showed that there is still possibility of acquiring the mutation in the RAS-MAP kinase pathways that was also associated with poor prognosis. So this is probably the mechanism of resistance for the use of such medication.
This is a question from Mohammed Jamal Abdul Wahab. He's asking about what is the role of gilteritinib in post-transplant maintenance.
So in this randomized study, there was improvement in the overall survival for those who were able to maintain or were able to resume gilteritinib post-transplant versus those who did not. There is ongoing randomized study for patient with FLT3 mutation, AML patient who went into transplant, so randomized patient between gilteritinib versus placebo. Again, this study, still there is no result yet, so probably we're expecting the result in the next 1 or 2 years.
There any more question? I think this is the last question. Thank you, Dr. Badr and Prof. Mahdi, for this comprehensive presentation. And that's when we conclude our session for today.
Thank you, dear speaker and moderator, Dr. Bakar, Dr. Mahdi, Dr. Badr. And we'll take 10 minutes break, and we'll be back after 10 minutes for the next session about chronic leukemias. I would advise you, dear attendees, to visit our exhibition. There is a very nice, attractive presentation by the sponsoring companies with a lot of informative information. So looking to see you after 10 minutes break. Thank you.
Thank you.
The floor is yours. You can go.
Okay. Assalamu alaikum. Good evening, everyone. My name is Ahmed Al-Said. I'm a consultant hematologist from National Guard Hospital, Jeddah. Would like to welcome you for session 3 of day 3 of annual Saudi Hematology Congress. This session will be about chronic leukemias. We will have 3 satellite sessions. Each one will be of 25 minutes, and then we'll have questions after each satellite symposium. So it's my pleasure to introduce the speaker for session 1, who is well known to all everybody in Saudi Arabia, Dr. Riyad Al-Faqih, who is a consultant hematology BMT, and he is head of clinical research department at King Faisal Specialist Hospital Research Center. Dr. Al-Faqih will speak today about second generation TKIs NCML management in the era of generic. This satellite talk is sponsored by Sudair Company. Dr. Riyad, floor is yours.
Thank you, Dr. Ahmed. Thank you, SSBD and Sudair and all the sponsors, as well as the attendees. So as Dr. Ahmed mentioned, the talk is about second generation TKIs and CML. These are my disclosures. However, I have no financial relationships with commercial interest with any entity of these. So this is my outline for the talk. I will go over a history, overview, and then management of CML. Philadelphia chromosome was first identified in Philadelphia, and this is why it was called Philadelphia. And it was identified by David Hungerford and Peter Noel. David Hungerford was at Fox Chase Cancer Center and Peter Noel at UPenn. And it was the first genetic defect linked to a specific human cancer. Then in late 1990s, STI 571 was identified as a tyrosine kinase inhibitor and paved the road for the use of kinase inhibitors in different disease entities. This was the result of the work of Nicholas Lydon team and Brian Drucker in Oregon. So this is 922 translocation that constitute the Philadelphia chromosome. And depends on where this translocation happened, you can end up having many transcript size. The most frequent are P190 seen mostly in ALL, P210 in CML, and P230 in CML as well. There are other transcripts, but these are the most frequently seen. Now, this translocation leads to a continuous activation of the ABL gene tyrosine kinase, and this is what leads to the neoplastic development of cells. Now, if you don't stop this transformation or this continuous activity of this gene, what happens usually in the natural history of chronic phase CML is development of mutation, other genetic abnormalities, and eventually blast crisis, which is a terminal event for these patients, very dangerous event. Now, this is the German CML registry. Here you see the incidence of blast crisis before the TKIs and with the advent of TKIs. The blue curve is before TKIs with the use of busulfan or hydroxyurea. As you see, 70% transform to blast crisis. As a matter of fact, 100% transform, but these 30%, the leftover 30%, are the ones who received the transplant, and this is why they did not transform. And the green curve shows you in the TKI era or imatinib era, very minimal rate of transformation with the introduction of these agents into the treatment of CML. So we now know, the definition of specific response criteria, the desired time point to achieve these remissions, and we know very well how to risk stratify our patients based on SOCAL, Euro, or UTOS scores. This is the definition of different remission criteria: hematologic, cytogenic, and molecular. I will not go over the details, as you all know these. And then this is the optimal time to achieve these responses or what we call milestones in the treatment of CML, and what constitute a warning at a specific time point if these responses were not achieved, and what's considered as a failure. So in general, our goal when we treat CML is to achieve remission, long-term control, avoid progression to last crisis, good quality of life, and in some patients nowadays we tend to target treatment-free remission, which is a remission without the need of TKIs. So this is in general the scheme on how we think about the treatment of CML. First of all, does the patient have high-risk CML or no? If no, then the other question that comes along is TFR a goal? If yes, then we prefer to use second-generation TKIs. If no, then we prefer imatinib. And if the CML is high risk from the get-going, then second-generation TKIs may be preferable. How did we come to these algorithms in the management of CML? We start with the prospective trials in the front line. Here's the IRIS trial, a very famous trial, randomized patients to imatinib versus interferon and cytarabine. This trial allowed a crossover, and despite the crossover, as you see here, imatinib was a winner and became a new standard of care for these patients. Now, after the IRIS trial, other agents were introduced, and here you see the nilotinib that was compared to the standard imatinib in the INEST-ND study. Pretty much very comparable baseline population in both arms, or in the three arms, as this study had an arm of a higher dose of nilotinib, 400 milligram, as compared to what we use nowadays, 300 milligram, and then the imatinib standard arm. And as you see here, this is at 12 months here, the major molecular remission rate, and the winner is the dark blue, which is the 300 milligram BID nilotinib as compared to 400 and to imatinib. So here also you see the rate of responses keep going up as the time goes by. Here at 24 months, you see the rates of major molecular remissions are higher in the nilotinib arms, but there is no difference between the 300 and 400 milligram dosage. And here you see the complete cytogenetic response at 12 months. As you see, the winner is nilotinib 300 BID versus the other two arms. And after nilotinib, the decision trial was set up to compare dasatinib to the standard imatinib. And here you see the baseline characteristics in both arms. Dasatinib 100 continuous versus imatinib 400 were pretty much carrying similar characteristics. And then here you see the disposition of patients on this trial. As you see, the majority received the treatment and continued on the treatment, actually. And here you see the rate of complete cytogenetic response by 12 months, 83% versus 72% statistically significant in favor of the dasatinib 100. The major molecular response rate by 12 months, 46 versus 28% in favor of the dasatinib, and very statistically significant as well. Here you see it in a graphic way. As you see on this is the upper graph is the complete cytogenetic response, and as you see, the dark blue is the dasatinib, the yellow is imatinib. So the rate of cytogenetic response is higher at 12 months. Here you see it. You see the major molecular remission also in favor of the dasatinib. Of course, the side effect profile is different in between both agents, where more myelosuppression happened with the dasatinib and more pleural effusion. However, more fluid retention happened in imatinib as well as rash. This is the cumulative incidence of major molecular rate over time. And as you see, at 5 years, it was higher, 76% in the dasatinib versus 64% in the imatinib. Here, you see the MR 4.5 or deep molecular remission at 5 years, 42% versus 33% in favor of the dasatinib 100. The other trial we have in this setting, comparing a second-generation TKI to the standard imatinib in the front line, is the B4 trial. And that trial compared bosutinib to imatinib. And as you see here, the baseline characteristics of these patients pretty much very balanced and comparable, and the drug disposition also showing that the majority of patients continued on therapy on this trial. And as you see here, in dark blue is bosutinib, in yellow is imatinib. This is at 12 months. The major molecular remission rate was 47.2 for bosutinib versus 36. And here you see MR4 and MR4.5 or deep molecular remission, also in favor of bosutinib as compared to imatinib. Side effect profile was also different. Here with the bosutinib, you see more diarrhea, more LFTs and pancreatitis, and with the imatinib, you see more of fluid retention. This is the major molecular response at 12 months, 47.2 bosutinib, 36.9 imatinib, statistically significant. Complete cytogenetic, 77% for bosutinib, 66% for imatinib, also statistically significant. Now, as I said, these agents have different toxicity. Here you see imatinib is well known for muscle cramps, fatigue, edema, nausea, and diarrhea. Nilotinib is known for arterial events, prolonged QTc, hyperglycemia, and pancreatitis. Dasatinib is known for pleural effusion, pulmonary hypertension, prolonged QT, and the platelet dysfunction. Bosutinib is known for the GI side effects, mainly diarrhea, liver function, pancreatitis, as well as rash. And of course, there is a financial toxicity for all these agents. Now, this financial toxicity is becoming less with the advent of generics, and now we have imatinib and dasatinib available in generic forms. So in a nutshell, all these TKIs are highly effective in the front line. There is no overall survival benefit comparing this second generation to imatinib, the standard of care, but these second generation lead to a faster and deeper remission and lower rates of progression compared to imatinib. Now, imatinib has the longest record of safety and efficacy and is available as generic. Usually we consider second generation in patients with high risk CML and when we aim to for treatment-free remission. Otherwise, we would treat the patients with the standard imatinib. Now, other scenarios where you may need to change imatinib in the front line is toxicity profile if the patient is intolerant for imatinib, which is the standard and the, as we said, the low risk. And you see here the first trial, which compared changing to dasatinib with intolerance. And as you see here, the majority of side effect resolved 75.2% in patients who developed toxicity on imatinib. So this trial showed that the efficacy and the symptom burden improved in these patients, changed, and this suggests that switching to dasatinib in patient intolerant for imatinib is an option. The other scenario where you may need to change your treatment from first line to second, from first generation to second generation is when you don't achieve your milestones on time or your response on time. And this is a trial called the CERN. Here you see patients at 3 months who did not achieve the desirable depth of remission were randomized to dasatinib 100 or continued on imatinib 400. And here you see at 1 year, almost a third of patients switched, achieved a major molecular remission versus 13% on a patient who continued on imatinib. And here you can see it in a graphical form where dasatinib is the blue curve and imatinib is the green curve. So this study supports that monitoring of these patients and switching to second generation dasatinib in this case.
Maybe we lost Dr. Riyad.
I think connection. I have to notify him. I'll talk to him.
Technical support, please. Ahmed, mute yourself, please.
Moment.
Dr. Samir, mute yourself, please.
The floor is yours, Doctor.
Okay, so sorry for this technical problem. Here we go back. Again, dasatinib is available now as a generic in Saudi Arabia under Sudair Pharma. It's called dasatinib SPC. And I have few slides to go over to show you the study that led to this approval. So as you see here, this is a product approved by Saudi FDA. The study was run by the International Pharmaceutical Research Center, comparing dasatinib 140 milligram generic to the original Sprycel 140 milligram in healthy individuals. The generic that comes to Sudair Pharma comes from a Spanish firm called Centon BV, and that trial was done with 128 healthy subjects, again, randomized to 140 Sprycel versus 140 generic. Here you see the bioequivalence curve exactly superimposed in between dasatinib 140 milligram generic and the Sprycel, no difference or whatsoever. And the AUC data was also superimposed, which tell us that this drug is pretty much similar to the original medicine. So basically this generic dasatinib got Saudi FDA approval. It has already US FDA and EMA approval, and it is approved for the same indication indicated for the original Sprycel, ALL, and CML. And in all forms and dosage forms. So last slide is about the second line options. Sometimes the front line option fail, and in that scenario, we have to assess the patient for adherence, drug-drug interaction, herbal supplements, and if none of these exist, a full disease reevaluation is usually done. Then the choice of therapy here is multifactorial, depending on what frontline therapy the patient received, the tolerance, the patient comorbidities, and the presence or absence of Abl kinase mutation. And in this line, the options are either higher dose of imatinib, or any of the second generation TKIs, or of course the third generation TKI ponatinib, if the patient is carrying T315I mutation. With this, I will finish and happy to take any questions.
Thank you, Dr. Riyad, and sorry for the technical issues. I don't see question, but maybe I will start. One practical question, Dr. Riyad, we see it sometimes, since there is approval of many generics, especially for imatinib, and sometimes we see patients given by pharmacy different generics. At like one visit he will take from this generic, next visit he will take from another generic. What is that okay? What is the impact of using different generics at the same time? Any data with or against this approach?
So you're right, this is a frequent problem. And actually, this is not recommended. If your pharmacy uses different generic, one from a different company each time, this is not recommended. The side effect profile may change, as the carrier molecules may be different, and then the tolerance, the adherence to the medication may change. So it is recommended, if you use a generic, first of all, to have bioequivalence study showing that it's exactly the same as generic. This is very important. And to use the same firm or company, because again, the carrier molecules may change, tolerance may change, and as such, the adherence will change, and the result, of course.
Thank you, Dr. Riyad. So I don't see a question, and I think because of sake of time, we can move to second satellite symposium, and it's my pleasure to introduce Dr. Samir Al-Amoudi, who was a consultant hematology and section head of adult stem cell transplant and cellular therapy at Prince's Neuro-Oncology Center, King Abdulaziz Medical City, National Guard, Jeddah, who will moderate for session 2. Dr. Samir. Dr. Samir, are you there?
Hello, can you hear me?
Yeah, okay, go ahead, Samir.
Can you hear me? Oh, okay, thanks, Dr. Ahmed, for the introduction. Yes, I want to thank the SSBD for organizing this meeting, and special thanks for Johnson for arranging this satellite symposium. So it's my pleasure to introduce next speaker, Dr. Lydia Scarful. She's well known. She's assistant professor in internal medicine in San Rafael in Milano, Italy. She has interest in chronic lymphocytic leukemia, and she has more than 25 publications in the chronic lymphocytic leukemia. And in the next 25 minutes, the talk will be about new horizons in CLL management. Okay, go ahead, Dr. Lydia.
Good afternoon, everybody. Thanks so much for having me today. It's a great pleasure to discuss with you new horizons in CLL management. And I'll start with what it is or should be the current management in first line, because the most relevant changes we are expecting in the next future are related to first line treatment. But based on the ESMO guidelines, you can see that even in 2021, the room for chemoimmunotherapy combination is very small, and basically they are only indicated in patients with very favorable disease features who are young and fit, because they are good candidates for the combination of fludarabine, cyclophosphamide, and rituximab. For all the other categories, you can see that basically either continuous treatment with BTK inhibitors or fixed duration combination of venetoclax and obinutuzumab are suggested as most suitable first-line treatment. And these results, of course, are derived from the information we gather from studies basically since the beginning with ibrutinib, where you can see now we have a long-term follow-up of the RESONATE-2 trial, where ibrutinib monotherapy in first line was compared with the standard of care at that time of chlorambucil. And you can see an impressive 61% of progression-free survival at 78 months of follow-up, with a benefit that is consistent across all subgroups. And the use of ibrutinib was challenged in first-line treatment compared to chemoimmunotherapy, and all studies in the fit and unfit setting in young and elderly patients confirmed an advantage in terms of progression-free survival for patients treated with ibrutinib compared to standard chemoimmunotherapy, including FCR and BR. And on the left, you can see the results of the E1912 trial, where ibrutinib was compared with FCR, and in the Alliance trial, the three-arm of ibrutinib plus rituximab and BR were compared in the elderly population, and the ibrutinib-based arm show a statistically significant benefit in terms of progression-free survival. And these results were actually confirmed most recently by the UK FLAIR study, where again the combination of ibrutinib and rituximab was compared with standard chemoimmunotherapy with FCR. And with a median follow-up of 52 months, the median PFS in the ibrutinib rituximab arm was not reached, while FCR median PFS was 66 months. And at variance with the E1912 study, where also an overall survival benefit was shown for patients treated with the combination of ibrutinib and rituximab, here in the FLAIR study, no overall survival benefit was demonstrated. But the main reason for this is explained by the fact that the vast majority of patients who progressed on FCR actually cross over to novel targeted agents and received chemo-free combinations. Two other options became recently available in first-line setting. One is based on the acalabrutinib treatment and is administered at continuous treatment, and acalabrutinib can be administered alone or in combination with obinutuzumab. The point I want to make here is that with the combination of acalabrutinib and obinutuzumab, up to 38% of patients with CR obtain undetectable minimal residual disease status. This being a desirable goal in terms of long-term disease control. And the same point was actually done by the combination of venetoclax and obinutuzumab, that is a fixed duration regimen, where the median PFS after 4 years of follow-up has not yet been reached. And the treatment duration is 12 months, and a relevant proportion of patients was able actually to obtain undetectable measurable residual disease. So the 2 points in the future management of our patient with CLL might be that we want to obtain undetectable measurable residual disease in order to administer time-limited combination. And this is actually the rationale behind the design of the Captivate study that was updated at the last ASH meeting. Here you can see the study design. There are 2 cohorts, one as an MRD-driven strategy, and a second one is based on fixed duration treatment. The results of the MRD guided cohort were recently updated. Here you can see that in the design of the study, after receiving 12 months of combined treatment of ibrutinib and venetoclax, after 3 months of ibrutinib lead-in, patients were assigned to different cohorts. Those with confirmed undetectable measurable residual disease were randomized to placebo or ibrutinib 1:1. While those without undetectable MRD were randomized to ibrutinib alone and ibrutinib combined with venetoclax. The group previously presented the 1-year disease-free survival, that is a sort of combined endpoint where clinical progression and MRD relapse are both collected. And you can see that the 1-year disease-free survival was between 95 and 100% in the undetectable MRD cohort. The most recent analysis updated the results of the 2-year disease-free survival in the undetectable MRD cohort. The patients enrolled into the study were younger than the general population of CLL, because there was a high limit of age of 70 years. The patient characteristics are actually quite superimposable in all cohorts. And the 2-year disease-free survival actually was exactly the same, meaning that no new disease-free survival events occurred between month 12 and month 24 after randomization. This is the curve where you can see that there was no statistically significant difference between ibrutinib and placebo, and the disease-free survival rate was extremely high. If we also analyze the 3-year progression-free survival, meaning we take into account only the true progression event, Again, you can see that there is a very high progression-free survival at 36 months of 95% in the placebo arm and 100% in the ibrutinib arm. And this holds true also in the cohort of unconfirmed MRD, where the outcome basically of ibrutinib plus venetoclax and ibrutinib alone are the same with a 36-month PFS of 96%. In terms of complete response and undetectable MRD, what you can see is that continuing treatment with ibrutinib or with ibrutinib plus venetoclax in those with residual disease is actually increasing the CR rate only in the first year in those with residual disease at the end of the combination. While more or less the same concept is applicable to the undetectable MRD, meaning that those with undetectable MRD after 1 year of combined treatment increase with the combination of ibrutinib and venetoclax, in particular during the first year of combined treatment after the initial 12 months. And the results were more or less the same in the peripheral blood and in the bone marrow. And this is a relevant concept in terms of study design, meaning that this should probably be taken into account when we define the duration of treatment in first line. With prolonged follow-up and prolonged treatment, actually the safety profile remained the same. As expected, patients were experiencing diarrhea, nausea, and neutropenia as most frequent adverse events. And only few patients had actually to discontinue treatment due to adverse event. In comparison, based on the results of the MRD, you may argue that a patient should be managed according to MRD status, but what is also relevant to note is that the primary analysis of the fixed duration cohort of the same study actually showed that a very high overall response rate of up to 96% can be obtained with a fixed duration treatment of 3 months ibrutinib followed by 12 months of combined ibrutinib and venetoclax. And even though 60% of patients obtain undetectable MRD in both peripheral blood and bone marrow, actually the progression-free survival of the whole cohort at 24 months is still very high, basically regardless the MRD status at the end of combined treatment, and it's about 96%. So it's still debated if this combination should be based, the duration of treatment should be based on the MRD status at the end of the first 12 months of combined treatment. The same combination was actually investigated in the setting of elderly patients or patients with a relevant comorbidity burden in the GLOW study. Here, the random is actually against chemoimmunotherapy, so patients with 17p deletion or TP53 mutation were excluded, and the standard arm at the time of the study design was the combination of chlorambucil plus obinutuzumab. At the last ASH meeting, the updated results with the median follow-up of 34 months were presented, and the focus of the analysis was actually on the undetectable MRD status that was evaluated by next-generation sequencing techniques, allowing us to go down as to 10 to the minus 5 in the analysis of the residual disease. The 30-month PFS was actually a little bit lower than what was shown in the Captivate study, meaning that in this patient cohort, the 30-month PFS was 80.5%. That was, of course, definitely higher than the results of the combination of chlorambucil and obinutuzumab. And here you can see that a relevant proportion of patients experience at least one adverse event in both arms, with the most frequent one being represented by neutropenia and infections. So one possible explanation is that the dose intensity of the combination of ibrutinib plus venetoclax could have been lower in this population of elderly and unfit patients. The results in terms of undetectable MRD are very impressive. Here you can see that up to 50% of patients obtain undetectable MRD in bone marrow at the level of below 10 to the -4, and 40% obtained a level below 10 to the -5. This benefit with the combination of ibrutinib and venetoclax was consistent across all subgroups of patients, including patients with unfavorable disease features. And what is very remarkable is that the undetectable MRD status was analyzed 3 months after the end of treatment, and then checked again 12 months after the end of treatment. And while patients treated with chlorambucil plus obinutuzumab had experienced MRD relapse over time, so only a small proportion of patients confirmed with undetectable MRD 12 months after the end of treatment in the chlorambucil plus obinutuzumab arm. Here you can see that the vast majority of patients with undetectable MRD 3 months after the end of treatment confirmed this undetectable MRD status 12 months after the end of treatment. So the level of response is maintained over time after completing the combination of ibrutinib and venetoclax. And in terms of first-line treatment, I just want to briefly touch upon the results of the Gaia trial that was also presented at the ASHC meeting. Here you can see the study design that was actually targeting younger patients, or at least fit patients, because one of the arm of the randomization was including a chemoimmunotherapy, FCR or BR, based on the age of the patients. And FCR, BR were compared with the combination of venetoclax plus rituximab, the combination of venetoclax plus obinutuzumab, or the triplet venetoclax, obinutuzumab, and ibrutinib. And one of the co-primary endpoint of the study was the undetectable MRD rate at month 15 in the 4 arms. And I'd say it was not expected. Still, the chemoimmunotherapy arm had the lowest MRD rate, while all the other chemo-free combination reached higher undetectable MRD in the peripheral blood at month 15. And the highest one was obtained with the combination of venetoclax, obinutuzumab, and ibrutinib, and was up to 92%. There was a concordance in terms of bone marrow undetectable MRD at final restaging that reached up to 78% in the triplet combination. And this benefit in terms of undetectable MRD was also confirmed when we applied high sensitivity flow cytometry. The last few words I would like to spend with you are about the management of relapse patients, because you have seen we have a lot of very effective options in first line, and we are thinking of new combinations for fixed duration treatment. But then we are facing an unmet need in patients who have received and were treated with both BTK and BCL2 inhibitors. And at the last ASH meeting, we have seen the results of a novel non-covalent BTK inhibitor. The most widely tested is pirtobrutinib. And here you can see that in the study, in the BRUIN study, more than 260 patients were enrolled, with CLL with that were heavily pretreated. The median line of treatment was 3, and all of them have previously received a covalent BTK inhibitor, and they had very high percentage of high-risk molecular features. And with the non-covalent BTK inhibitor, pirtobrutinib, actually the vast majority of patients obtained an improvement, or at least the disease stabilizes, with an overall response rate of 68%, and the drug was effective both in those who discontinued BTK inhibitor for progression and those who discontinued BTK inhibitor for toxicity, regardless of the presence of BTK C481S mutation that is associated with ibrutinib resistance. And more preliminary results were also shared at the ASH meeting for a second non-covalent inhibitor called nemtabrutinib. So in the end, I just want to share with you the conclusion that the BTK inhibitors are actually effective in frontline, and we have a lot of data and long-term follow-up for ibrutinib. It is currently uncertain how to combine venetoclax, so if the best partner for venetoclax is a BTK inhibitor or an anti-CD20. We are still investigating the appropriate duration of novel agent combination therapy, and if the treatment duration should be guided by MRD. And in the relapse setting, the data presented about reversible BTK inhibitors raised hope that we can still control the disease at the time of relapse in patients previously exposed to both BTK inhibitors and BCL2 inhibitors. And with that, I thank you for your attention, and I'm happy to take any questions.
Thanks, Dr. Lydia, for your presentation and this overview. So I cannot see any question in the chat, but I have a question. So in your opinion, so now do you think like outside the clinical trial, should we target as a physician MRD in treating CLL?
That's a very good question. Thank you for asking. Actually, at our site, for example, we are not testing MRD outside clinical trials, but we have definitely many clinical trials currently ongoing that are collecting this information because it might be relevant in the near future to tailor treatment duration and our treatment strategies based on the MRD level, but we are not still there. And the first step would be either say to standardize the assay, because for the flow cytometry analysis, actually the European Research Initiative on CLL has already proposed and standardized a panel, while for the NGS analysis, I think there is still work to do to obtain a standard test that should be used in clinical trials first and then hopefully in clinical practice.
Okay. I have a question, Samir. Samir?
Okay, go ahead, Dr. Ahmed.
Dr. Lydia, so in Captivate and GLOW studies where we use the 2 or 3 big guns in front, which showed excellent results. Is there any data about patients who progressed after using these combinations up front, what to do with them later?
Thank you for the question. Actually, in the Captivate study, they collected this information. I mean, there were 12 patients who relapsed after having stopped the treatment with ibrutinib and venetoclax in undetectable MRD, and they were all retreated with ibrutinib. Only 9 were accessible, let's say, for response, and they all got a partial response. So also from a biological standpoint, if the patients are relapsing and they are not on treatment, they could be retreated with the same treatment they received before with a high chance of responding again. Of course, it also should be also taken into account the interval between treatment stop and relapse in defining the treatment strategy.
Okay, good. But one more question, I think, because I cannot see any question in the chat. So in the Captivate trial, in the rule in the like a maintenance with the group that unconfirmed MRD, who had both combination ibrutinib and venetoclax. As you show in the graph, there was no difference between the group who had ibrutinib venetoclax compared to ibrutinib. So was there any benefit adding venetoclax to that group?
I think that only in those who obtained the combination, who were treated with the combination of ibrutinib and venetoclax, they increased the depth of response and the rate of undetectable MRD. But we are still, because we are, let's say, partitioning the group, it's still a very small number, so I'm not sure this is a statistically significant increase. But they had a higher rate of undetectable MRD when they were treated with the combination of both ibrutinib and venetoclax. But as you correctly pointed out, this did not translate in improved survival benefit. So I dare say the follow-up is still short. I mean, probably we need more time to see if there is any difference.
Okay. Okay. Thanks a lot, Dr. Lydia, for having you with us today. It was a great talk. I hope we see you physically again, inshallah, next year.
I hope the same.
And
thank you.
And I want to thank SBD and Janssen for arranging this Satellite Symposium. Thank you. Saeed, so leave the mic to you.
Okay, thank you, Dr. Samir. So we come to the last satellite talk, which will be sponsored by AstraZeneca. Thank you for sponsoring this satellite symposium. So the last symposium will be, the title is In-Depth Review of PTKIs in CLL, and it will be presented by Prof. Wojciech Warszak, who is a consultant hematologist and professor of hematology at Jagiellonian University, Krakow, Poland. His most research activity was related to development of monoclonal antibodies in B-cell lymphoma and stem cell transplant. And Prof. Warszak participated in over 70 clinical trials. He was a co-author of publications leading to registration of ibrutinib, adalimumab, belinostat, lenalidomide, venetoclax, and rituximab biosimilar. And at present, his research is focused on developing second-generation PTK inhibitors. So, floor is your Prof. Wojciech.
Good afternoon, anyone. My disclosures. And warmly welcome from Krakow. We have the largest main marketplace in this part of Europe. Unfortunately, it's rather overcrowded now, as in the last week, over 800 refugees fled to Poland from Ukraine, and most of them are passing through our city. It is the true full-scale war, which we've never experienced in Europe since World War II. Therefore, I'll try to keep my presentation short. CLL is the disease of the elderly people we know very well. But CLL is the disease of the low dynamics, and there is little or none role of cytostatics, which are ideal drugs for dynamic disease. As you see, the drugs we have are BTK inhibitors or IP3K inhibitors, so interfering with the B-cell receptor pathway, modern monoclonal antibodies, or BCL2 inhibitors. Now we have 3 generations of Bruton tyrosine kinase inhibitors. Ibrutinib is the only representative as the first generation inhibitor. Very efficient drug, but it has an off-target stimulation of other TEC kinases. In here, you have a kino, which demonstrates that all second generation BTK inhibitors are much more terse and to the point. And what's presented in the table is the average IC50, which means that the smaller the value, the stronger the inhibition. So as you see, ibrutinib inhibits very well Bruton tyrosine kinase, but it also inhibits TEC kinase and EGFR, as opposed to the second generation drugs. So atrial fibrillation, possibly due to ibrutinib metabolism, is very frequent. We literally don't see it in the second generation inhibitors. Bleeding complications and thrombocytopenia are likely to be secondary to the TEC kinase inhibition. Diarrhea may be related to EGFR inhibition. So all those adverse events, we do not observe them, or they are much less severe in the second generation inhibitors. But let me show you a couple of laboratory values. Here you have in vivo thrombus formation model, and as you see, the model from the patients treated with acalabrutinib in a yellow line is the same as the healthy individuals, as opposed to what we observe in ibrutinib. The same is true for infections. As you see, the antidependent cellular cytotoxicity is slightly impaired in acalabrutinib treated patients and very severely impaired in ibrutinib treated patients. Therefore, acalabrutinib is a safe drug.
It's looking for the camera.
And
haven't found
it's
it
tested
yet.
in over a couple of thousand patients in the randomized clinical studies. Its development is consequent. In the next couple of minutes, I'll try to persuade you that it's one of the best choices we have. We published the pooled analysis of the safety data, and a couple of things I want you to realize. The infections, yes, we do observe them, but after the second year, there is literally no increased numbers. They do not happen. The new infections don't happen. So acalabrutinib on the long time run is a safe drug. If we look at this atrial fibrillation or other cardiac problems, they are minor, if any. We do observe, and this we have to underline, the worrying numbers of secondary primary malignancies, where this is possibly due to the long drug exposure and to the sole fact that the patients with CLL live longer. So the traditional approaches in CLL therapy are gradually replaced by targeted approaches. And this is absolutely true in the second line and also in the majority of patients in the first line. The ESMO recommendations for the first line therapy are less dramatic than in US, where chemoimmunotherapy is not allowed at all. But certainly ESMO recommends targeted therapy in all those with TP53 mutation or 17p deletion, in all those with unmutated EGHV status, but it also allows and does not make it compulsory in all first-line CLL patients. If we look at the old data, the upgrade of FCR regimen, and you see that in fact only patients with the best prognostic subgroup without any mutations, without any 17p mutations or deletions, and with a mutated EGHV status have a plateau and are doing reasonably well. It means that FCR should not be given unless we could diagnose the patient in a very modern way, unless we are certain that we are not missing 17p deletion or p53 mutation, and unless we are certain that we are not missing the unmutated EGHV patients. The 17p deletion patients are doing particularly bad unless treated by BTK inhibitors. The old data from ibrutinib, this is a pooled analysis from all the studies we've done, and acalabrutinib, as you see, even better, median progression-free survival not reached. Now, in the first line, one of the very old trials we had is ibrutinib versus chlorambucil, which is important is to understand that there is no overall survival difference. Therefore, we are not allowed to start therapy with chlorambucil, even if we think it will be beneficial for the elderly patients, as it doesn't look very harmful. No, there is no overall survival difference. We should not. But there are a couple of further experiments, and we thought that additional monoclonal antibodies will improve the results. So we checked ibrutinib with obinutuzumab versus chlorambucil with obinutuzumab, striking progression-free survival difference. The same with BR and with FCR. In FCR study, which was done in a younger population, there was additional and overall survival difference, which means that we are not allowed to give FCR unless we have a clear diagnosed mutation, EGHV mutation status, because we are allowed to offer FCR only to IGHV unmutated patients. Sorry, mutated patients, because with non-mutated, there is a great difference. So let me guide you through the Elevate treatment naive study, which was published in Lancet in 2020. And in this study, we took all elderly patients and randomized them to obinutuzumab plus chlorambucil, which was the standard after the German study, the German CLL study group studies. And this was challenged against acalabrutinib and acalabrutinib plus obinutuzumab. The primary endpoint was progression-free survival, and you can see the striking difference of both acalabrutinib arms. Now, there was no overall survival difference, but the study allowed for the crossover. And as you see, there's just a fine summary of all Bruton tyrosine kinase inhibitors in the first line, all three-phase studies. Whichever the study we look at, they were always better. Just to mention, we have an alternative. Recently, Fisher suggested the time-limited therapy with venetoclax plus obinutuzumab, which also is relatively better than chlorambucil plus obinutuzumab. We'll come back to the time-limited regimens. And let me update you on what was on ASH this year or last year. There was a FLAIR study in which was FCR regimen against BTK inhibitor with rituximab, again with a meaningful difference, and what we would have expected the difference hold in unmutated patients. The only patients which we could treat, again the same conclusion, is those with EGHV mutated status, which means the best prognostic subgroup. I don't even want to mention the 11q deletion or the 17p deletion, that's evident. Now for the other genetic abnormalities like 13q deletion or normal karyotype, the differences also exist. Then a Captivate study is a time-limited therapy where we gave ibrutinib plus venetoclax, and then there was a fancy randomizations for those with undetectable MRD, that was ibrutinib versus placebo, and those which could not, where we could not prove the undetectable MRD, or it was not confirmed, against ibrutinib, and continuation of ibrutinib plus venetoclax. And you see in both arms the super results, ranging from 95 to 99% of progression-free survival. And the MRD-guided treatment following the joint use of BTK and BCL2 inhibitor showed continuous efficacy. and 2-year disease-free survival rate was 95 to 100%. Now, what shall we do in a relapsing refractory setting? Here, we not only want to give it in the mutated patients and those who are in short remission, but also we recommend to give it in those who relapse after the long time remission. And let me start with the ASCEND study. But before that, there was the old study we've published with Professor Zelenets in 2017, proving that idelalisib plus rituximab was better than bendamustine and rituximab. However, it didn't become the standard of care because of adverse events. And the ASCEND study was in fact the first study we had, which was the face-to-face comparison of the BTK inhibitor and, in fact, IP3K inhibitor, as the majority of 150 patients randomized were assigned by the doctors to idelalisib plus rituximab. The primary endpoint was progression-free survival. And as you see, there's a typical demographics for the relapsing refractory setting with 18 patients with 17 P deletion, 25 to 28% of patients with 11 Q deletion. And here it is, the essence. 85% of patients discontinued idelalisib plus rituximab due to toxicity. There were 60% of patients experiencing severe adverse events versus 20% in acalabrutinib. The acalabrutinib arm was definitely better in all physicians, against physician's choice and against both used treatment modalities, idelalisib plus rituximab or bendamustine plus rituximab. And this was regardless 17p deletion, regardless the mutation status of EGHV. We analyzed all subgroups, and in all pre-specified analysis, we could demonstrate that acalabrutinib arm was better. There was a trend towards overall survival, but it has to be mentioned that 49% of the patients from idela rituximab and bendamustine rituximab arm were crossed over to acalabrutinib. Therefore, we have no force to detect overall survival difference in this study. Compatible response rates and toxicity. And as you see, apart from the minor headaches, which are transitory, usually do not require medical therapy, just a cup of good coffee, the acalabrutinib was much better, specifically in terms of neutropenia, pyrexia, infections, diarrheas, not mentioning this, which was characteristic for idelalisib, namely transaminase elevation and the others. So we could clearly see that acalabrutinib did not demonstrate any unexpected new safety signals in terms of adverse events of special interest. Atrial fibrillation was low, and so were hemorrhages and hypertension. Infections were the main drawback of idelalisib. Therefore, at 3 years follow-up, we can reassure in the ASCEND study that acalabrutinib maintained an acceptable tolerability profile. The study met its primary target, and the data support the use of acalabrutinib in patients with relapsing refractory CLL. Now, we've done another comparison, which is a head-to-head comparison of acalabrutinib versus ibrutinib. These patients took only the patients with 17p or 11q deletions, so high risk. The primary endpoint was a non-inferiority, which was met. But I want to draw your attention that around 15 months, there was a trend towards separation of those curves. Again, it was confirmed by a subgroup analysis. Again, we could clearly demonstrate that number of adverse events, including the adverse events leading to treatment discontinuation, were much less frequent in acalabrutinib arm. If we look at the study, the adverse events of special interest like atrial fibrillation, hypertension, or the bleeding events, they were significantly much less common. So, before we go to atrial fibrillation, I would like to show you one result, which is from CLL patients not treated by BTK inhibitors. You see that there is a natural tendency due to the age of the patient of developing the atrial fibrillation. Therefore, the atrial fibrillation and flutter we observe in acalabrutinib arm is exactly what we would have expected in the population, much smaller, twice as smaller as in ibrutinib. The same thing with hypertension, but also bleeding events, diarrhea, arthralgia, all those adverse events which we are worried about. So in elevator relapsing refractory study, again, it was the first head-to-head comparison, which met its primary endpoint. We demonstrated significantly lower rates of adverse events of special interest, particularly cardiac events. And also there were less frequent treatment discontinuation and severe grade 3 adverse events. Another head-to-head comparison we've done was Alpine, and it was a slightly different study where we took all relapsing refractory CLL patients, not just the high-risk group, randomized towards ibrutinib versus zanubrutinib. And here, the primary target, the primary endpoint was a response rate, but we could demonstrate a significant difference in progression-free survival. But again, I want to remind you that around 17-month acalabrutinib study was not at all that worse. We could see the separation of the curves, but these studies are not comparable because in our acalabrutinib study, we took only high-risk patients, and in zanubrutinib comparison, all patients. Therefore, summary, the study met its target, and again, there is another proof that a second-generation BTK inhibitor should be used in relapsing refractory setting. Going towards the end, I would like to show you the Bruin study, which is pirtobrutinib, a third-generation BTK inhibitor. And I think that most striking message is in this chart, where you can see in dark blue, the patients where BTK were discontinued due to progression, and a light blue where they're discontinued due to toxicity. So in fact, those light blue cases could have been easily treated with a second generation BTK inhibitors, while those with dark blue could not. And as you see, there was the excellent response rate to pirtobrutinib in monotherapy. And pirtobrutinib is a non-covalent inhibitor, and it's the hope for the patients with a relapse, with a secondary disease, with a refractory disease, which is not a primary refractory, but secondary refractory. However, before we end, I still have to say that there is a time-limited option. We had venetoclax plus obinutuzumab in the first line, and here we have a Murano protocol. I sometimes call it a victory under Murano, the first time-limited protocol showing the striking difference against chemoimmunotherapy. And on ASH meeting, we had a lot of combinations of BTK inhibitors with venetoclax or with other BCL2 inhibitors, sometimes with monoclonal antibodies as well. Therefore, the take-home messages are that targeted therapy is an undebatable standard of care in relapsing refractory patients. And this is even by ESMO guidelines. Now, targeted therapy is moving to the first line. It's an approved standard in a 17p deleted patients or with p53 mutated patients. It's an emerging standard of care for all untreated CLL patients. And this is ESMO guidelines because in NCCN, which is an American guideline, this already is a standard of care for all untreated CLL patients. Now, the second thing we should understand is that the new generation BTK inhibitors may prove to be better to ibrutinib because they have better safety. And because they are safer drugs, less patients are terminated on the therapy is terminated and less patients, so therefore they might be slightly more efficient. Now, we should be reminded that we have randomized clinical studies proving that if we have a intolerance of ibrutinib, we should switch to second generation BTK inhibitor. And this is the standard. However, we should always ask ourselves the question, specifically as if in Saudi Arabia, both first and second generation inhibitors are in the same price. Why shouldn't we start therapy in all patients with the second generation BTK inhibitors, which are much better tolerated? Now, the other thing we have to have in mind is that the regimens with BCL2 inhibitors may allow in selected cases the time-limited therapy. However, we have a lot of evidence that the BCL2 inhibitors work after in patients with BTK inhibitors failure, so we can safely use BCL2 inhibitors after acalabrutinib failure, giving the patients another life. Now, we are not so certain whether the BCL2 inhibitors will work this nicely after BCL2 inhibitors or after BTK inhibitors. We do not have any clinical studies demonstrating that the reuse of BCL2 inhibitors will be as effective as its primary use. There is a hope, but we do not have the proof. And we know that the joint use of BCL2 and BTK inhibitors may be interesting, however, is more toxic. Therefore, its usage in elderly individuals, specifically low-risk patients, may be at question. So I think that it's we are fully entitled to say that inhibition of both BTK and BCL2 are alternative solutions which we could possibly use together. Neither of the drugs could be regarded superior, and we should take a particular patient, look at the goal we have, and choose the best of them. So once again, I hope that what we have in Central Europe at the moment will fade away, and that we will still have a sunny marketplace instead of the marketplace full of refugees. I understand that in the Middle East, you observe it in a much closer way. We are observing the things which happened in Syria and other countries, but unfortunately now is happening very close to our borders. Thank you very much indeed.
Thank you, Prof. I think you are live with us now. Oh,
absolutely.
Nice to have you with us, and hope you and all people there are safe. So we'll go for questions. I don't see question yet, but I could start. Now we have many BTK approved for front line and CLL line, and the second line. We have ibrutinib, we have acalabrutinib, and most likely zanubrutinib might be approved after ALPINE trial. So now, how much is the toxicity profile of patients should impact on the choice of BTK inhibitors for CLL patients?
Thank you for this question. I think it's a matter of accessibility and a matter of price. If one can afford the second generation BTK inhibitor, I would not prescribe the first generation at all. There is no difference as far as efficacy is concerned. BTK inhibitors are definitely not worse, are possibly better drugs in terms of efficacy, but they are definitely safer. The toxicity profile is much better for the elderly population. And indeed, looking at CLL patients, elderly population with cardiac diseases is what we are really facing. So I would recommend to initiate the second generation BTK inhibitor in literally everyone, unless we have a very young individual or a very high risk case, where we would rather go for the combinations.
Good. So another question for a patient with 17P. Always we discuss the issue about continuous versus fixed duration treatment. So any updates on this issue?
Well, a very difficult thing, because if you have a time-limited therapy, it's usually more toxic. However, it has its charm because it may allow to discontinue the therapy after a year, if we look at the first line, after 2 years, if we are looking at the relapsing refractory setting. However, there are two questions. The first one is, will BCL2 inhibitor work if we reuse it on the second time? And the second question is, will at all BTK inhibitor be efficient after BCL2 inhibitor? Therefore, what we may say now is that we have a lot of evidence that treating patients with upfront BTK inhibitors is safe and efficient. And in terms of developing a refractory disease, we have a well-proven answers. We can either go for the third generation BTK inhibitor, or we can go for venetoclax. Now, we do not have a lot of data that the reverse is true. Therefore, the venetoclax and other BCL2 inhibitors are great drugs, but simply I do not have a feeling that they are 100% safe in terms of a long-lasting effects, in terms of the answers to the future therapies.
There is a question from the audience. How about secondary malignancies in Elevate RR? Can you elaborate more on this?
We do observe secondary primary malignancies in all CLL patients. I would say the longer they live, the more we observe. Now, what is worrying, and we pinpoint this, that if we look at our patients treated with acalabrutinib, let's say after the 2 years and then after 4 years, the number of secondary primary malignancies is slightly increasing. We are observing this. It is not yet statistically significant in a way that it's a disaster, but it should be very thoroughly looked at.
Okay, another question about using a lower dose of ipratinib. Could this reduce the toxicity of ipratinib and maintain the efficacy?
Well, we don't know. Out of my experience, I may tell you that we've treated over 400 patients with ibrutinib, and because at that time, none of other targeted therapies were refunded in our country, we really wanted to keep the patients within the clinical studies. So we did our best to reduce the doses, to treat the atrial fibrillation. Well, it's possible, but it means an additional attention. And sometimes, despite what we do, we fail. So my way of thinking is that decreasing the dose is not a good idea. It's, if we have the intolerance of first generation BTK inhibitor, it's a classical situation where we should switch into the second generation BTK inhibitor. Now, I want to remind you the studies where it was clearly demonstrated that in 3/4 of the cases, switching from the first to second generation allows first to carry on therapy, and adverse events either disappear completely or grossly diminish.
Okay, maybe the last question. Is there any toxicity where you will not think of switching from ipratinib to second generation, but you go for venetoclax, for example, bleeding, for example, or other toxicity?
It all depends from the patient, because again, venetoclax is the drug which requires attention. So if we have the patient in facilities to observe this patient carefully, we are more eager to change it than if we have the patient where we want to give him the drug and let him go. But I would say that in a patient who is having a severe clotting problems and atrial fibrillation, these are not ideal patients for BTK inhibition, and therefore, once those developed, I would rather go for BCL2.
Okay, so thank you, Prof, for excellent presentation. And with this, we come to the end of this satellite and session 3 of day 3. I'd like to thank all the speakers. I'd like to thank all the sponsors, and I'd like to thank Dr. Amal and her amazing organizing team, and Dr. Amal. Thank you.
Thanks a lot, Prof. Thank you, Ahmed, for moderating the session. Again, I would like to thank all the speakers for all the presentation. Thanks all the company for their support and sponsoring the event. It's not yet the end of day 3, actually. We still have more to go. It's been a long day. We already go through 2 workshops, which is excellent, and all the satellite symposium. All the presentation will be recorded and uploaded in the YouTube channel. If you don't have a chance or you miss any of the workshops or the presentation, you can reach them in the YouTube channel. And we have more to go, so we'll go for a break. We would like to have you at 7 o'clock by Saudi Arabian time. So we'll have the part 1 of the hematologic malignancies symposium coverage for leukemias. We will have 4 eminent speakers, very well-known speakers from the United States to cover the leukemias at 7 o'clock. Meanwhile, keep you safe. Have a visit to our virtual exhibition. Enjoy that. And looking to have you at 7 o'clock exactly, inshallah, for the next part of the conference. Thank you.
Thank you.
Thank you.
floor is yours.
Hello?
Dr. we are live.
We are live.
You are muted, Dr. Adoy.
Assalamu alaikum warahmatullahi wabarakatuh. Good evening, everyone. I know it has been a long day for everyone, but we kept the most precious lectures to the end as well. No offense to the previous lectures. Allow me to introduce my my name is Dr. Asma Radu. I'm a malignant hematology stem cell transplant consultant at King Abdulaziz University, Jeddah. I'll leave the chair to my colleague, Dr. Ahmed Al-Ataibi. Please. Dr. Ahmed, can you hear us? Allow me to, it actually gives me a great pleasure to introduce our first speaker for this session, Professor Mark Litzow. I was also always fascinated about his work. Professor Litzow is a professor of medicine at the Division of Hematology at Mayo Clinic. He's also was the director of the BMT program at Mayo Clinic from 1992 to 2008. He's still an active member of the bone marrow and transplant program. He's also the director of the myeloid disease-oriented group in the Division of Hematology from 2002 to 2016. Also being the vice president of the CIBMTR twice, and actually the list goes on. He's also an author of over 480 manuscripts and multiple book chapters. I don't want to take much of the time allocated for this session. Professor Mark, the floor is yours.
Well, thank you very much. It's a great honor for me to speak to you today. I was asked to discuss how to manage adolescent and young adult ALL in first relapse, whether to consider novel agents or conventional chemotherapy. So, as you may well recall, some years ago, Dr. Wendy Stock from the University of Chicago showed that adolescents who were treated by pediatric oncologists in the children's cancer group in the United States had better outcomes than this same age group treated on adult protocols through the CALGB group. And you can see there was a 20% improvement in event-free survival. There were a number of reasons for this improvement, but some of this related to the higher doses of non-myelosuppressive drugs like vincristine, corticosteroids, dexamethasone listed here, and asparaginase compared to myelosuppressive drugs. And so these pediatric intensive regimens were adapted to adolescents and also young adults. And first group that showed a benefit for this was the French GRAL group. And this is a study that they did, a phase 2 study, showing that patients aged 15 to 45 had a 58% event-free survival versus it was 46% when they tried to extend this up to 46 to 60-year-olds. And this was because the older individuals had a higher treatment-related mortality. But these were certainly better results that we were seeing in adolescent and young adults compared to using adult regimens. And here in the United States, Dr. Stock led a prospective phase 2 trial using a pediatric intensive regimen from the children's cancer group and showed that there was a 2-year overall survival of 79%. And the results were similar regardless of the age of the patients. And this study treated patients up through 39 years of age. So the question then became to us is, do these patients need to have bone marrow transplant in first remission? This had been our practice up to this time in adults with ALL. And so Dr. Matthew Wiedewelt looked retrospectively at 263 patients who had been treated on this C10403 protocol that I just showed you, and then compared these outcomes to 217 related donor, unrelated donor transplant recipients in the same age range that have been reported to the Center for International Blood and Marrow Transplant Research here in the United States. And most of these transplant recipients received myeloablative conditioning with TBI, and again, 80% had a matched related or unrelated donor. And what this study, which was just published last year, showed that the patients that received chemotherapy had better outcomes than those who received the transplant. That's on the dotted line. And you can see the upper left curve is for overall survival. I'm sorry, apologize, I'm looking at my slides on my computer and not advancing. So this was the doses of chemotherapy. This is the French study showing their results. These are the results from the C10403 study that showed the excellent survival regardless of age. And then this was the transplant study that I was just referring to, comparing the chemotherapy patients to transplant patients. And here are these survival curves that I'm showing you. I can't see it very well on my phone here, so I'm looking at my slides on my computer, but also will show you on the phone here that you're seeing. So you can see that the overall survival was much better with chemotherapy. The disease-free survival in the upper right was also improved. And then you can see on the lower left that the relapse rate was lower with the chemotherapy. You can see the p-values. And the non-relapse mortality, as you might anticipate, was much lower with chemotherapy compared to transplant. Again, the dotted lines are transplant and the solid line is chemotherapy. So we feel now that for these patients in first remission, that most of them do not require transplant in first remission. And especially if they achieve MRD negativity, we think that there's a high chance that they can be cured with chemotherapy. So this is our current practice for most of these patients. If they remain MRD positive, then we think that we need to consider them for transplant. Or if they have high-risk features such as a pH-like phenotype, then we consider them for transplant. And I think you're all familiar with the entity of Philadelphia chromosome-like acute lymphoblastic leukemia. These are patients that have a gene expression profile that overlaps with pH-positive ALL, but they don't have a Philadelphia chromosome or a BCR-ABL gene mutation. They generally have a poorer prognosis, as I'll show you. They have a variety of genomic alterations. There's two main classes. There's ABL class fusions that I show you here, ABL1, ABL2, CSF1R, and PDGFR beta. And they can often respond to a tyrosine kinase inhibitor. And then there's also alterations of CRLF2, JAK2, and the EPO receptor that activate the JAK-STAT signaling pathway, and they may respond to JAK inhibitors such as ruxolitinib. And then there's a variety of other kinases that are activated that I have listed here. And on the upper right is a figure from this publication from Saratazian that shows the multiple different mutations that are associated with this pH-like phenotype. So a number of studies have looked at outcomes in these pH-like patients. And this was a study that my ECOG Akron group participated in 798 patients with B-cell ALL ages 21 to 86. The first thing to note is that this pH-like phenotype the incidence is similar in young adults and older adults, as you can see on the lower left. And the majority of alterations are in the CRLF2, 51%, whereas the other subtypes are less frequently seen. What this study also showed by Catherine Roberts and the JCO, first you can see on the upper left that young adults have a better prognosis than older adults for both event-free and overall survival in the lower left. But if you then compare how these patients do with a pH-like phenotype compared to patients who have B-cell ALL but don't have a pH-like phenotype, you can see that the outcomes are poorer over on the right graphs for both event-free survival on the upper curve and for overall survival on the lower curve. So these pH-like patients, I don't have time to show this, but they often are more often are MRD positive also when they're treated. So typically we would consider these patients for transplant at first remission. So you're all familiar with the concept of minimal residual disease, and I won't elaborate on this in this talk. But patients that have a complete MRD response can still suffer relapse, though at a less frequent rate than patients who are MRD positive. So this brings us to some of the new therapies that we now have available to us that are immunotherapies, and on the upper right is blinatumomab. On the lower right are the antibody conjugates, with the best example being inotuzumab ozogamicin. And then on the lower left is the CAR T cell therapy. And these are the three main entities that we have available to us now. And so when we have a patient that's in relapse, what kind of treatment should we consider? Well, these have all been studied, these three agents in this setting. Inotuzumab ozogamicin is an anti-CD22 antibody linked to calicheamycin. Calicheamycin is a cytotoxic agent, and so the inotuzumab, the antibody, delivers this to the leukemic cell, where then it can be activate and induce killing of the cell. This is a similar structure to Mylotarg or gemtuzumab ozogamicin, which is an anti-CD33 antibody linked to calicheamycin, which is active in acute myeloid leukemia. So the INNOVATE study was conducted, and patients were randomized to get inotuzumab, and these were patients that had relapsed refractory CD22 positive ALL. Either get inotuzumab or standard of care chemotherapy, which you can see in the orange box on the lower right. This was either FLAG or Ara-C plus mitoxantrone or high-dose Ara-C. And they, again, were randomized 1-to-1, and pH positive or pH negative patients were eligible. And what you can see is that there was a very high CR/CRI rate with inotuzumab, just over 80%, whereas the standard of care chemotherapy was 33%. And many of these patients were able to achieve MRD negativity with the inotuzumab, 78% versus 28% for standard of care chemotherapy. And in both arms, most patients achieved their remission after one cycle of treatment. You can see with inotuzumab it was 73%. For the chemotherapy, it was 91%. However, most of these patients were destined to relapse with either the inotuzumab or the standard therapy, although the duration of remission was longer with inotuzumab and the progression-free and overall survival were longer, particularly it seemed where you can see the curve split late on the right side for overall survival with inotuzumab versus the chemotherapy. So those are the results of inotuzumab and suggest that this agent is more active than chemotherapy. Now, blinatumomab is the second agent that we have available to us. And this is a bispecific T-cell engaging antibody. So it links a variable region of an anti-CD3 antibody to the variable region of a CD19 antibody. And Therefore, it brings a T cell in close proximity to the leukemic blast where killing can occur. And a similar study was done with blinatumomab, as had been done with inotuzumab. This was the Tower study. This one was a 2-to-1 randomization, as you can see, relapse refractory, pH negative B cell ALL. And they either got blinatumomab or, again, standard of care chemotherapy, similar to what was seen with inotuzumab, FLAG, high-dose methotrexate, high-dose Ara-C, or clofarabine-based regimens. And you can see some of the stratification factors. And this study was also published by Dr. Kentarjian in the New England Journal. And you can see that the top curve is overall survival, the improvement with blinatumomab for both the overall survival. The second curve, the B curve, is results censored at the time of stem cell transplant, and the lower curve is event-free survival. So again, showing a benefit for blinatumomab compared to chemotherapy. And then, as you may know, blinatumomab was also tested for patients with minimal residual disease. So these are patients that were in first or second morphologic remission, less than 5% blasts. They again received blinatumomab, and as you know, this is given by a 4-week continuous infusion. In the Tower study, there was a lower dose that was given 9 micrograms per day for 1 week, and then it was dose escalated to 28 micrograms, and this was tried to lessen the risk of cytokine release syndrome. So in this study where it was given for minimal residual disease, the primary endpoint was MRD status after 1 cycle. And this is achieved in nearly 80% of patients. And this was had also a similar rate had also been seen in a prior pilot study. Now, these patients can get cytokine release syndrome and also can have neurologic events, which we can also see with CAR T cell therapy, as we know. In this setting, some of these patients were able to remain in remission without further chemotherapy or transplant. But in general, we feel that these patients should be considered for transplant once they achieve MRD negativity. And it was on the basis of this study that the FDA also approved blinatumomab for MRD positive patients. So it's now approved for both full-blown relapse or refractory disease, but also for MRD positive disease. And then I want to talk about CAR T cell therapy. And this is, again, I think known to you, this is where lentiviral vectors or other viral vectors are used to add antibody to a T cell, which is then directed against a tumor cell. I don't know if my animation comes through on the slides that you can see. I'm not sure that it does. But anyway, this is bringing a T cell in close proximity to the tumor cell by different mechanism than blinatumomab, but inducing killing. And as we know, this is highly effective in treating ALL. Patients undergo a leukapheresis where their T cells are collected. These then go through the transduction process where the antibody is introduced with retroviral or lentiviral vector. These T cells are then expanded. The patient receives lymphodepleting chemotherapy, which is number 4 there, and then the T cells are subsequently infused into the patient. And this is shown, excuse me, this is shown remarkable remission rates, and these are heavily pretreated patients, often in second, third, or fourth relapse. And you can see the high response rates that have been seen over on the right side, up to 90%. Now, this is associated with cytokine release syndrome in a high percentage of these patients. Fortunately, it's not severe in many of these patients. We don't have time today to go over the management of cytokine release syndrome. Anti-IL-6 antibodies, notably tocilizumab, plays a key role. So given these high remission rates, this was the study that confirmed the high remission rates that were seen in these patients and led to the FDA approval, excuse me, here in the United States for patients under the age of 25, and that happened actually back in 2017, and you can see the high survival rate with these patients, although not a plateau in the overall survival curve. But this led to the question of whether these patients could be candidates to not necessarily receive a transplant. And on this curve, you can, on this slide, you can see this was a study from Memorial Sloan Kettering that Dr. Jay Park led. And what I've highlighted in the red insert is that about 40% of these patients had less than 5% blasts. So these were MRD positive patients, whereas there was also a group 51% that had greater than 5% blasts, and then some patients with extramedullary disease. And some of these patients had received prior blinatumomab. Now, this was a relatively small study, 53 patients, but what Dr. Park showed was that the patients that had a low disease burden, you can see on the upper left and upper right for event-free and overall survival, that they had a better outcome than patients with a high disease burden. So these were patients with over 5% blasts. But if you look down below in the lower left curve and then the lower right curve, it appeared that outcomes were similar whether these patients went on and got a transplant or not. Now, obviously, this is relatively short follow-up, but it raised the question of whether patients that get CAR T-cell therapy and have a good response need to have a transplant or not. Now, more recently, we got the results of what's known as the ZUMA-3 trial. This is a different anti-CD19 CAR T-cell product. This was presented by Dr. Shah, and I'm in gratitude for him for his slides at the ASCO meeting last year in 2021. And these were older patients, ages 19 all the way up to age 84. You can see the characteristics of the patients. About a quarter of them were Philadelphia chromosome positive. Nearly half had gotten prior blinatumomab, a quarter had gotten prior inotuzumab, 42% had a prior transplant. And what this study showed was 71% CR/CRI rate. You can see that on the left side. And then smaller numbers that got blast-free bone marrow, and then 16% that had no response. And on the right side, I show that the MRD negativity rate was 97% in the responders. So these were quite good remissions. And these are the survival curves from the study. The purple is the CR/CRI patients. The red is the non-complete remission patients, and the black is the overall survival. And on the right, you can see the relapse-free survival for the patients that got CR/CRI, and the black is all patients that were treated. Again, there was cytokine release syndrome that was seen, but it was greater than or equal to grade 3 in only a quarter of the patients. And then the neurologic events were shown on the the lower left. So at a median follow-up of 16 months, a single infusion of this CAR T product, the KTE-X19, showed a high durable response rate in these heavily pretreated patients. The CR/CRI rate was 71%, with most of these patients achieving MRD negativity. And on the basis of this study, the FDA approved, the trade name is Tecartus, for relapse refractory B precursor ALL. And this is for all adults now, not restricted by age. The previous product, the Tisagen Leclosil, was just for patients under the age of 24, whereas this is for all adults. So what data do we have on whether patients need to have a transplant once they get CAR T-cell therapy? I showed you some data from Memorial that suggested that patients may not. This is some pediatric data. This is 50 children and adolescents and young adults up to age 30 who were treated with CAR T-cell therapy. Of the 28 patients that achieved an MRD negative CR, 21 went to a consolidative allogeneic transplant. You can see the event-free and overall survival for the allotransplant patients on the right side there. The 7 patients who did not go to allotransplant all relapsed at a median of 5 months post a CAR T infusion, and none of them achieved a complete remission following a second CAR T infusion. So this suggested that patients ought to be considered for transplant. And then there was this study looking at pediatric patients aged 1 to 25 from the Seattle group. And they showed that in these 50 patients, consolidated transplant improved leukemia-free survival in patients with no prior history of a transplant, with a trend towards significance. The p-value was 0.09. Patients with a prior transplant going to a second transplant, that was not clear. Patients who had a functional persistence of the CAR T cells of less than 2 months, including those with a prior transplant, and that's in these patients, transplants significantly improve leukemia-free outcomes. And this just shows the data for this from this study. The red curve is transplant and the black is no prior transplant. Leukemia-free survival on the left and overall survival on the right. So my conclusions and recommendations are that for Ph-negative AYA-ALL patients in relapse, to achieve a second remission, I would use immunotherapy. Oh yeah, sorry. I apologize. So this is the second study, the patients age 1 to 25, and showing the benefit. Let me go back. I'm trying to do this on my phone and on my computer. So this was where I said a consolidative transplant included leukemia-free survival in patients with no prior history of transplant. The benefit was not evident when restricted to the patients who had a prior transplant, but patients with less CAR T persistence, including those with a history of prior transplant, there was an improvement in leukemia-free survival with transplant. And this just shows the curves, the transplant in the red dotted curve, and the black is the patients that did not get transplanted. So my recommendations are that immunotherapy should be considered for these patients with B-cell ALL when they relapse. Typically here we use blinatumomab. We haven't had CAR T outside of a study. We now have CAR T therapy available to us. Certainly inotuzumab can be considered, although if you're planning to take the patient to transplant, there is some risk of sinusoidal obstruction syndrome with the inotuzumab, and particularly it can be seen after transplant, so we tend to shy away from using the inotuzumab and rely more on blinatumomab. It's obviously immediately available. CAR T-cell therapy could certainly be an option. I think these patients should be taken to transplant. I think I acknowledge that the data is somewhat controversial. but we don't have long-term follow-up with CAR T therapy, and I think that transplant still needs to be considered as the best option for these patients. And I think there's really, I won't say no role for conventional chemotherapy, but I think it's more limited given these immunotherapeutic options that we currently have available to us. So with that, I'll conclude and acknowledge some of my colleagues around the United States and who have contributed to these studies and have certainly supported me through my career. I thank you for your attention, and I apologize that I didn't always advance the slides in a timely way. I hope you can certainly feel free to make my slides available to the participants. Thank you very much.
Thank you very much, Dr. Litzel. Thank you for this elegant and nice lectures and nice recommendation. And we apologize for you and for the audience for this technical issues. We'll leave the question after the second lecture. So it's my honor to present our next speaker, Dr. Hagop Kantarjian. Is well known to you. He's a professor and chair of Department of Leukemia, MD Anderson Cancer Center, Houston, Texas. Professor Kantarjian is well known for his contribution in hematology and leukemias. He has more than 1,800 peer-reviewed papers and publication. Dr. Kantarjian need no introduction. Dr. Kantarjian, welcome and thank you for accepting our invitation. The mic for you. And Dr. Kantarjian will speak to us about AML, the state of art in 2022. The mic for you, Dr. Hagop.
Thank you for the opportunity to present to the Saudi Society of Hematology. I'm going to update you over the next 30 minutes on what we do in acute myeloid leukemia at MD Anderson. So as you know, much of the progress in AML has been associated with the deciphering of the genomic landscape of AML, which showed that 95% of the patients will have mutations which can be prognostic, predictive, and targetable. And the targetable ones are the most important in terms of the application of our newer therapies. So we know that 30% of the patients have FLT3 mutations, which can be targeted with FLT3 inhibitors. 20% of the patients have IDH1 or IDH2 mutations, and we can target these with the new IDH inhibitors. And we also know that patients with MLL can be targeted with the new menin inhibitors, which I'll show at the end. So how do we apply the molecular studies in acute myeloid leukemia? If we have FLT3 mutations, we use FLT3 inhibitors, either with low intensity or with intensive chemotherapy. And the preferred agent is gilteritinib in our book. And then we consider transplant and post-transplant maintenance with FLT3 inhibitors. If they have IDH1/2 mutations, we use an IDH inhibitor, enasidenib in the case of IDH2 mutations, ivosidenib in the case of IDH1 mutations. Now, most importantly are patients which may have P53 mutations. Now, these patients, we do not have good target, but we're trying the CD47 antibodies. And then finally, patients with translocation 11q23, where we use the menin inhibitors. As you know, as of 2017, we have 10 agents which are FDA approved, 9 of them for specific indications of acute myeloid leukemia, and the 10th one, oral, is decitabine, has been approved for MDS and CMML, but it can be used in the replacement of the HMA inhibitors, either subcutaneously or intravenously. So at the top, you see the 2 FLT3 inhibitors which have been approved, midostaurin in combination with chemotherapy and frontline therapy, gilteritinib as a single agent in the salvage setting. And as I mentioned, at MD Anderson, we use the gilteritinib in combination in both salvage and frontline therapy. The next 2 drugs are the IDH inhibitors. The most important drug is not targetable in terms of a mutation, but it targets the BCL2 overexpression, and therefore has been approved and is the backbone of therapy of much of our frontline therapy in older unfit AML, but also in the younger patients. And finally, the two oral hypomethylating agents, and I'll make an important point that they are not interchangeable and they are not similar to each other. So first, I'm going to start with the 5 to 10% of patients which have acute promyelocytic leukemia. These patients now are curable without chemotherapy. In 2000, we started using ATRA and arsenic trioxide in combination. We add the CD33 antibody gemtuzumab in patients who have high risk of disease or a white cell count over 10,000. And then there's maintenance for 9 months with ATRA 2 weeks on, 2 weeks off, arsenic trioxide 5 days a week for a month, 1 month off, 1 month off, and the total is about 80 doses. When we did this without the chemotherapy, in the younger patients on the left side in the green curve is the potential cure, which reaches close to 100%. On the right side are the older patients. So even though they are older, because it's an easy therapy, we can still cure 90% of the patients. And as of this ASH meeting, you may have seen that the Chinese have investigated ATRA with an oral formulation of arsenic trioxide in 38 patients. They showed that the complete molecular response rate is 100% without any relapses. So in the future, it's possible that we will be treating APL with 2 oral agents, and we could cure almost all the patients. The next category are the patients with core binding factor leukemia. These are about 15% of the patients. These are the patients that have inversion 16 or translocation 821. And here, all we did was to combine the older chemotherapy with gemtuzumab ozogamicin. So we give them the induction and then consolidation for 5 courses. And we are now using gemtuzumab instead of any anthracyclines. And what we see is with the use of this regimen, we are able to cure again close to 80% of the patients. So it's very important in core binding factor leukemia to add the gemtuzumab to the chemotherapy. Now we're going to talk about the rest of the 80 to 85% of the patients who do not have either APL or CBF AML, and most of the leukemia experts still consider 3+7 as the standard of care. I think 3+7 should be retired after 50 years of reasonable experience with it. Now, what is 3+7? 3+7 is daunorubicin 60 milligram per meter square daily for 3 days, and cytarabine for 7 days. And then if there's disease on day 14, the patients are given 2+5. Then they are consolidated with 4 cycles of high-dose RAC or allogeneic stem cell transplantation. The reason I say it's not a good regimen is if you look on the left side at the younger patients under the age of 60, the cure rate as best is 35%, 5-year survival, 35%. On the right side are patients who are over the age of 60 who can take this kind of intensive chemotherapy. And what you see is even when you can deliver this kind of intensive chemotherapy, the median survival is under a year and the estimated cure rate is probably less than 10%. Now we have better intensive chemotherapy regimens for the younger patients and better low intensity therapies for the older patients. And that's why I say that 3+7 should not remain the standard of care. Now, how do we improve on this? In addition to improving on the intensive chemotherapy, we can add targeted therapies. So I'll show you the data with the FLAG-IDA and CLIA-venetoclax, but I'll show you also the combination of adding FLT3 inhibitors, IDH inhibitors, and maintenance therapy in these patients. And we already discussed the gemtuzumab ozogamicin, and hopefully in the future, there'll be better antibody targeting drug conjugates. So what do we do at MD Anderson in the younger patients? We give them either FLAG-IDA or CLIA with venetoclax. If they have FLT3 mutations, we add the gilteritinib and skip the venetoclax. Once they are in complete remission, If they are candidates for allogeneic transplant, we do that, and then 2 years of maintenance therapy with either azacitidine venetoclax or with targeting therapies such as FLT3 or IDH inhibitors. If they have no transplant option, then we do 6 consolidation cycles with FLAG-IDA or CLIA venetoclax, and then we still do the maintenance for 2 years. So what is FLAG-IDA or CLIA? It's essentially induction with high-dose RAC with idarubicin, and we add a nucleoside analog, an adenosine nucleoside analog, either fludarabine or cladribine. On this slide, I summarize what we published already with the FLAG-IDA venetoclax and the CLIA venetoclax. So we have close to 100 patients. These have been published in JCO and with Lancet Hematology. And I compare them now to intensive chemotherapy with similar regimens without the venetoclax to show the value of venetoclax, not only as part of low intensity therapy, but also in combination with intensive chemotherapy. So when we look at the intensive chemotherapy with venetoclax and compare it to the intensive chemotherapy FLAG-IDA or CLIA without the venetoclax, you notice that we have an improvement in the overall survival. And here now the 2.5-year survival is close to 60%. So we're not talking anymore about a cure rate of 35%. On the right side is the event-free survival, again, close to 60%. On this slide, I show the outcome by minimal residual disease. So the patients who become flow cytometry MRD negative have a potential 5-year survival, which is quite high, close to 70%. But still the patients who are MRD positive are still doing very well with a potential cure rate close to 40%. On the right side is the benefit from allogeneic stem cell transplantation. So it's always better to try to get the patients to transplant, but the difference is becoming more marginal and may disappear in time. Other people are doing the same. So this is the Italians who have done the fludarabine idarubicin RAC, and they show the results in NPM1 mutated AML, which is favorable. And then what they show is that, in fact, if the patient is NPM1 mutated and FLT3 ITD positive, still the cure rate is close to 50%. It's only the patients who are NPM1 negative and FLT3 ITD positive who in their experience do poorly. But again, this is before the era of adding the FLT3 inhibitors. So what they show is, in fact, a 3-year survival of 60%, demonstrating the benefit of those new regimens, such as FLAG-IDA over 3+7. Now, other people are doing similar findings. So this is in older AML, and the study is from Australia, where they use 2+5 instead of 3+7 because the patients are older, and they added venetoclax. And in the de novo, newly diagnosed AML, so not therapy-related, the CR rate, marrow CR rate is 94%, and the estimated 3-year survival is 50%. This is in de novo older AML, where I showed you that the 5-year survival is less than 5%. So adding venetoclax to intensive chemotherapy when it's tolerated has been beneficial. And the role of venetoclax, in my view, is not only in the older unfit AML in combination with epigenetic therapy, as I'll show at the end. Now let's talk about FLT3 mutated AML. So as you know, there are now 2 FLT3 inhibitors which are FDA approved, midostaurin, gilteritinib. Quizartinib, I believe, is going to get an FDA approval soon, and sorafenib is commercially available. So we have 4 FLT3 inhibitors which are available. I think the 2 most potent ones and least toxic are gilteritinib, quizartinib. Gilteritinib has the advantage of covering not only the FLT3 ITD, but the TKD mutations. So as you know from the first study by Richard Stone, patients with FLT3 mutated AML received 3+7 with or without midostaurin. And for the first time, we showed the benefit of adding a targeted therapy, a FLT3 inhibitor, in terms of improving the survival in these patients. And the improvement in the survival was significant, about 10% at about 5 years. There are other studies that showed similar findings with the addition of FLT3 inhibitors. So this is a study which was reported from China in patients who received sorafenib maintenance post-allogeneic stem cell transplant. And what they show is after the transplant, if you add sorafenib compared to no treatment, you improve the 2-year survival from 68 to 82%. So again, it shows that transplant should not be considered as a one-time option, but it should be part of a continuous strategy, including pre and post-transplant targeted therapies. And this is a similar finding, which is now from Europe, where they took patients treated with allogeneic transplantation, and after transplant, they randomized patients to sorafenib or placebo, and they again showed the benefit of adding sorafenib to these patients in terms of improving both the relapse-free survival as well as the survival. And here what you see is that in FLT3 mutated AML, if you do everything correctly, including a FLT3 inhibitor, transplant and post-transplant maintenance, these patients are doing very well with an estimated cure rate of 70%, which I think can be further improved with better induction consolidation therapy and with gilteritinib instead of sorafenib. And this is the phase 1 experience with 3+7 with gilteritinib. This was given to all patients with newly diagnosed AML, but half of them had a FLT3 mutation. And what Dr. Prats reported is that the marrow CR rate is 82%, 0 4-week mortality, but look at the estimated 3-year survival. It's now close to 70%, which again shows the power of adding those new targeted therapies, in particular the FLT3 inhibitor. And this is our experience with CLIA and sorafenib. This was before the era of gilteritinib. So we treated about 50 patients, and you see the marrow CR rate is very high, 90 to 100%. And in our study, the estimated 3-year survival is over 70%. So this shows again the value of the targeted therapy in these patients. And here I want to show an announcement by a company which has the quizartinib. So Daiichi Sankyo has done a randomized study in 539 patients with FLT3 mutated AML who were randomized on a 1-to-1 basis to the addition of quizartinib versus just the chemotherapy. And they announced that the primary endpoint, which is overall survival, has been met. So we're waiting for the public announcement of the information in public meetings and perhaps the FDA approval for quizartinib, which will be limited to patients with FLT3 ITD mutated AML, not the TKD. Now, what about other targeted therapies? So this is the experience reported by Dr. Stein with 3+7 with or without an IDH inhibitor, depending on the IDH mutation, be it IDH1 with ivosidenib or IDH2 with enacidinib. So they reported an update at this ASH meeting that showed that this regimen produces a high CR rate, marrow CR rate, and also a 3-year survival of 60 to 67%. So again, targeted therapies added to chemotherapy is benefiting the patients. Now, as you know, for the longest time, people mentioned the dogma that maintenance therapy in AML does not work, unlike the situation in acute lymphocytic leukemia, or for that matter, in lymphoma and myeloma and other cancers. Now, this dogma was shattered by the QUASAR study, which was a phase 3 study that took patients who were 55 years or older with AML, who were in first remission for less than 4 months and could not receive the curative intensive chemotherapy or transplant. So they were randomized to either oral azacitidine, which is poorly absorbable, so it's 300 milligrams daily for 2 weeks instead of 1 week, versus placebo. And what they showed is a significant improvement in the median survival from 15 to 25 months. But what you see is that the curves meet at the 5 years. So we need to do better than simple oral azacitidine. Maybe the addition of venetoclax to HMAs could do that. This is another study. Now, this is with the subcutaneous azacitidine, again in older patients by the Hoban group, where they took 116 patients after 2 courses of intensive chemotherapy, and they randomized them to 1 year of azacitidine versus observation, and they showed a significant improvement in the 1-year disease-free survival. So again, proof of the concept that maintenance therapy works in acute myeloid leukemia. Now, people complain that maintenance therapy with HMAs is difficult because you have to either give intravenous decitabine or subcutaneous azacitidine. This is the study that was done with the oral 100% absorbable decitabine in MDS and CMML, which showed that, in fact, the oral decitabine has an absorption which is 99% of the IV, an overall response rate of 62% in MDS CMML, and the 2-year survival of 62%. So because of this, the FDA approved the oral decitabine for the treatment of MDS and CMML, but you can use the oral decitabine as an alternative to the parenteral hypomethylating agents in acute myeloid leukemia, which we are doing today. So the distinction between oral decitabine and the FDA-approved oral decitabine is the oral decitabine is 100% absorbable, 35 milligrams daily by mouth for 5 days. The approval is for MDS CMML, but at MD Anderson, we use it instead of any parenteral hypomethylating agent. The oral azacitidine has a poor absorption rate of 10 to 15%. So it's given at 10 times the dose, 300 milligrams daily, and it's given for 14 days. And the only indication is patients who are older, unfit AML in first remission. You cannot use it as an alternative to the parenteral subcutaneous azacitidine. It is not approved for that indication. Now, people worry sometimes that decitabine or azacitidine could be superior to the other. This is a study from Europe that shows that actually in 626 patients who received azacitidine or decitabine, the CR rate is identical, the marrow CR rate is identical, the mortality is the same, and the median survival is the same. So you can use either of those hypomethylating agents, and now we have to use them in combination. Now, all of us use, or many of us use antifungal prophylaxis in acute myeloid leukemia, and I think we should use it. I prefer posaconazole, and there are 2 studies now that show that the azoles are important in prophylaxis of AML. This is a study from French by Dr. Michalet, where they use the protected environment, the laminar airflow rooms, and they use posaconazole antifungal prophylaxis. And what they showed is that with this strategy, they showed that the addition of antifungal prophylaxis increased the CR rate by about 8%. And these are the patients who essentially benefit from the antifungal therapy. And this is another study that was reported at this ASH meeting by Dr. Schumann. And in this study, they used fluconazole instead of voriconazole or posaconazole. And what you see is that with fluconazole, the incidence of invasive fungal infection is higher, 24%. And that's why I favor voriconazole or posaconazole over the poor antifungal drug fluconazole. Now, when you use the azoles and you're going to use venetoclax, you have to adjust the dose. So if you use posaconazole, the dose is not 400 milligrams daily, but 50 milligrams daily, so 1/8 of the dose, which saves you a lot of money also. With the voriconazole, it's 100 milligrams daily, again, 1/4 of the dose, which saves you also a lot of money. Now we come to the older unfit AML. So we talked about the younger fit AML, the newer chemotherapy regimens with FLAG-IDA and CLIA, the addition of venetoclax, FLT3 inhibitors, IDH inhibitors, but the approval of venetoclax comes from the randomized studies in older unfit AML, where the VIALA-A study that looked at azacitidine or azacitidine plus venetoclax showed that the addition of venetoclax improved the survival significantly. from a median of 9.6 to 15 months. But when you look at the 2-year survival, even though it is much better, it's still close to about 35%. So we need to do better than this. And one of the questions is, can you use venetoclax in IDH2 mutated disease? And the answer is yes, because venetoclax is as potent as inacidinib in covering FLT3 mutated AML. And this is the randomized study, the subset analysis of the patients who were IDH mutated, showing that the addition of venetoclax improves the CR rate significantly from 4 to 44%. It improves the marrow CR rate from 11 to 80%, but most importantly, it doubles the median survival, and it increases the 2-year survival rate to 50%. Now, this is now the study with azacitidine with or without ivosidenib in IDH1 mutated AML, where I think the ivosidenib is superior to venetoclax. And this study has shown that the addition of ivosidenib almost triples the median survival. It triples the CR rate. And so for patients with IDH1 mutated AML or the unfit, I think azacitidine with ivosidenib may be better than azacitidine with venetoclax, but I think the triple regimen in the future with aza, venetoclax, ivosidenib may be best. And this study, which is a randomized study that was reported at this ASH meeting, shows again that the addition of ivosidenib has improved significantly the survival in these patients. So in older AML, as I showed you, the standard of care today is azacitidine with venetoclax. At MD Anderson, we use the triple nucleoside therapy with cladribine, low-dose Ara-C, venetoclax, alternating with NHMA with venetoclax. We always try to send the patients to transplant if possible. Otherwise, we continue this as a maintenance for 2 years. So the rationale for this was previous studies before the era of venetoclax, where we showed that alternating cladribine Ara-C with decitabine improved the median survival to 14 months, which is as close to the 14.7 months, which was reported in the randomized study. So we decided to use this combination and add the venetoclax. So this is what we call now the triple nucleoside therapy. So cladribine, Ara-C, and NHMA in combination with venetoclax. And what I show on this slide is the update in the first 60 patients with newly diagnosed AML treated with this regimen. True CR rate, 80%, significantly better than 3+7, and tolerable. The marrow CR rate is 93%, early mortality 2%, very tolerable. MRD negativity 84%. And now the 2-year survival is close to 60%. And in the subset of the 19 patients that we were able to take to transplant, they do very well. Now, even in the patients that we could not take to transplant, the 2.5-year survival is now 50%. So I'm hoping that this regimen in the future may become a new standard of care instead of hypomethylating agents and venetoclax in older unfit AML. And the last thing I want to point out is patients with acute myeloid leukemia with translocation 11q23. These patients have a very poor prognosis and they need to go to transplant. However, at the last ASH meeting, there was a study of a menin inhibitor, SNDX 5613, in patients with refractory relapse AML. Most of them had the translocation 11q23. And what this study showed that in the subset of the 38 patients with translocation 11q23, a refractory relapse
So thank you for Dr. Kantarjan. The lecture is completed. And thank you for our speaker for this part of our fifth session for today. Because of the time, we'll take quick questions. We have one question for Dr. Litso. The question from the audience for you, Dr. Litso. Would you still transplant MLL gene rearrangement ALL treated with pediatric protocol in first remission if they became MRD negative?
Yes, I think I would. I think that's a high-risk group. Can you hear me?
Yeah, we can hear you, Dr.
Yes, I think I would. I mean, my criteria for transplanting patients with a pediatric intensive regimen are if they're MRD positive, but also if they have high-risk genetic features. I will still strongly consider that. And there was some data from the French that had previously shown that as well. So that patient, I think I would still take the transplant even if they achieve MRD negativity with a pediatric intensive regimen.
Okay, thank you very much, Dr. Litso. Appreciate your participation with us. I think because of the time, we will not be able to take more questions. We'll move to our second part. I'll give the mic to my colleague, Dr. Uthman Radawi, to present our next speaker. Dr. Uthman, mic for you, please.
Thank you, Dr. Ahmed. It's my pleasure also to present the next speaker for the session. We will move actually to the last presentation, waiting for the presentation in the middle for Professor Brown to join us. So I will present Professor Samir Parikh. Dr. Samir Parikh is an assistant professor of medicine oncology in the Division of Hematology at Mayo Clinic, Rochester, Minnesota. Active and enthusiastic researcher within the CLL disease-oriented group. His research is focused in evaluating the role of prognostic factor and novel agents in CLL. He's also principal investigator and of several investigator-initiated industry-sponsored clinical trials. I would like, in the next 25 minutes, he will be telling us about frontline therapy for CLL in 2022, either using single agent versus doublet versus triplets, also for limited duration or continuous therapy. Dr. Samir Parikh, please start his presentation, please.
Hello, everyone. My name is Samir Parikh. I'm an assistant professor of medicine at Mayo Clinic in Rochester, Minnesota, and I'm delighted to present on the frontline therapy options for patients with chronic lymphocytic leukemia. I'm really thankful to the organizers for giving me the opportunity to present today. These are my disclosures. So over the next 25 minutes or so, I hope to cover the landscape of frontline therapy in chronic lymphocytic leukemia. Now, I'd like to begin with BTK inhibitors. So these two studies actually changed the paradigm for frontline management of chronic lymphocytic leukemia. On your left is the Alliance study, which was conducted for an older patient population with a median age of 71 years. Where patients were randomly assigned to one of three different treatment arms. The first one was bendamustine and rituximab compared to ibrutinib, and that was compared to ibrutinib and rituximab. As you can see on the left, there was an improvement in the progression-free survival for patients who received either ibrutinib-containing arms compared to bendamustine and rituximab. And on the right, you can see in a companion study, the E1912 study, where the median age of patients was 57 years, where treatment with ibrutinib and rituximab was compared to FCR. And in this study, you can see an improvement in the progression-free survival with the use of ibrutinib and rituximab compared to FCR. In fact, there was also an overall survival benefit noted with the use of ibrutinib in this study. Both of these studies actually led to the approval of ibrutinib in the frontline setting, as well as changed the paradigm for the management of CLL, and moved many of us away from using chemoimmunotherapy in the frontline setting, particularly in the younger patient population, with the improvement in the overall survival noted with the use of ibrutinib. So at this past ASH meeting in 2021, Dr. Jennifer Voyach presented the long-term follow-up results of the Alliance study in the older patient population. I'd like to draw your attention to the left, where you see that there is an ongoing difference between the progression-free survival in the ibrutinib-containing arms compared to bendamustine and rituximab although there is no difference in the overall survival. And this is important because this study allowed crossover between the bendamustine containing arms to ibrutinib, and therefore there is a likelihood that that resulted in no difference in the overall survival benefit. Importantly, you will notice that there is no difference in the progression-free survival between the ibrutinib alone and the ibrutinib and rituximab containing arms, suggesting that rituximab may not entirely be necessary in this group of patients. And therefore, in my routine practice, if I am considering an ibrutinib containing regimen, I typically will not administer rituximab at the same time. Here you can also see that there was no difference in the PFS noted in the solid blue line curve, which consists of patients treated with ibrutinib who had a TP53 abnormality, compared to the dotted blue curve where patients received ibrutinib containing regimen without a TP53 abnormality, again suggesting here that ibrutinib containing treatment was able to abrogate the high risk nature of the TP53 abnormality. Finally, improvement in progression-free survival was also noted across both mutated and unmutated IGBH arms, suggesting that this treatment works equally well in both groups of patients. At the ASH meeting last year, also, there was a presentation by Dr. Hillman and colleagues from the UK study group that described their results of the FLAIR study. This is a large phase 3 study that enrolled 771 patients that randomized these patients to 1:1 receiving either FCR or ibrutinib and rituximab. As you can see that there are minor differences in the way FCR is given. In this study, fludarabine and cyclophosphamide were both given orally compared to the traditional intravenous formulation that is administered in the US, which was designed by Dr. Michael Keating at MD Anderson Cancer Center. And in this study, the IR, or the ibrutinib and rituximab administration, was pretty much similar to what the E1912 study was. And as you can see on the right, both the treatment groups, including the FCR and the ibrutinib and rituximab, were very well balanced amongst the most common prognostic markers that we consider at the time of study initiation. Over here, you can see the results where treatment with ibrutinib and rituximab was associated with a superior progression-free survival compared to treatment with FCR, although there was no difference in overall survival between the two study arms. Now, this is in contrast to the E1912 study, where there was an improvement in overall survival in younger patients with the use of ibrutinib compared to FCR. There are a few thoughts as to why this may be the case. One is that patients received effective salvage therapy after after FCR stopped working in this particular study, where you can see that the vast majority of patients received a BTK inhibitor-based treatment, although these differences may not be entirely the correct reason. Another reason may be that this is an older group of patient population, and therefore they were able to receive effective salvage therapies at subsequent line of therapy. Regardless, this study again shows the power of ibrutinib compared to traditional cytotoxic chemoimmunotherapy in improving progression-free survival in the frontline management of CLL patients. Now, over the last few years, there have been a lot of new molecules that have developed that are better compared to ibrutinib with respect to their kinome map. So here is an example of the kinome map of second generation BTK inhibitors such as acalabrutinib and zanubrutinib. And as you can see that these molecules have much more specificity where they do not inhibit many other enzymes apart from BTK. And this led to the development of these molecules in the clinical trials that I'm going to present, and also led to the approval of many of these agents. The first study I'd like to discuss is the ELEVATE-TN study. This study is a randomized phase 3 study that compared acalabrutinib and obinutuzumab to single-agent acalabrutinib to chlorambucil and obinutuzumab in a predominantly older patient population. Those were greater than 65 years of age. The study allowed patients with deletion 17p, and a total of 535 patients were randomized 1:1:1 in these three arms, and the primary endpoint in this study was progression-free survival as assessed by investigators. Importantly, similar to the Alliance study, patients who had progression of disease on chlorambucil and obinutuzumab were allowed to cross over to single-agent acalabrutinib arm. These are the updated results that were published recently by Dr. Jeff Sharman and colleagues. And as you can see, the therapy with acalabrutinib containing regimens, either single-agent acalabrutinib or the combination of acalabrutinib and obinutuzumab, was associated with a superior progression-free survival compared to chlorambucil and obinutuzumab, clearly establishing the superiority of these of this agent in the management of frontline CLL. In my practice, I typically would not administer obinutuzumab in combination with acalabrutinib because, as you can see, there is a minor difference in PFS, and this is a secondary or an ad hoc analysis because the primary comparison is not between these two groups. Also, there is no difference in the overall survival between these two groups of patients. There is the added disadvantage of having patients to come in for an intravenous infusion with obinutuzumab, and with the current COVID-19 pandemic, there are a lot of patients who want to stay away from the hospital or want to avoid the added immunosuppression related to a anti-CD20 monoclonal antibody treatment. And therefore, in my practice, if I was to use acalabrutinib, I typically use it as a single agent. Nevertheless, you could consider it combining with obinutuzumab, perhaps in a specific subset of patient populations, such as those that have skin lesions or have membranoproliferative glomerulonephritis or other areas of disease process where they would like to have faster response to therapy. But this study established acalabrutinib as a solid frontline treatment option for patients with CLL and is now actually approved in the US for this indication. A similar study design was established for patients who received zanubrutinib, and this was compared to bendamustine and rituximab in the Sequoia study. Dr. Con Tam and colleagues presented the results of these data at the recently concluded American Society of Hematology meeting in 2021, and you can see in this cohort 1 where patients with untreated CLL who did not have evidence of deletion 17p were randomized either to single-agent zanubrutinib or bendamustine and rituximab. And in the study, 241 patients received zanubrutinib and 238 received bendamustine and rituximab. One thing I'd like to draw your attention to is that despite the exclusion of patients with deletion 17p, you can see that approximately 6% patients had a TP53 mutation, which is important to note because in the absence of deletion 17p by FISH, there is a substantial number of patients, about 6%, that could have a TP53 mutation. And therefore, in practice, it's important to ensure that you check for both a mutation as well as deletion 17p by FISH to look for evidence of TP53 mutation. Regardless, the results were not surprising. Patients who received zanubrutinib had a superior progression-free survival compared to bendamustine and rituximab. And I think these study results will lead to the approval of zanubrutinib in the frontline setting in the US. With the current follow-up, there is no difference in overall survival between the two groups. And much similar to ibrutinib-containing regimens, there is an improvement in PFS for both mutated and unmutated IGV8 subgroups, suggesting that zanubrutinib is a very effective treatment option in the frontline management of CLL. Now, we talked about 3 BTK inhibitors, ibrutinib, acalabrutinib, and zanubrutinib. Each of these has a different toxicity profile, but they all have class effects. And over here, you will note that the vast majority of adverse events of interest include bleeding, hypertension, arthralgias, infection, and diarrhea. And as you will note that the risk of bleeding appears to be lower with ibrutinib compared to acalabrutinib. I think a lot of this is a function of follow-up time interval. And as you can see over here, these are long-term follow-up data from the Alliance study where Dr. Voyage presented data of risk of atrial fibrillation, which continues to increase over time. And similarly, on your right, you can see the risk of new or worsening hypertension that actually also worsens over time, suggesting that these are cumulative incidents, cumulative toxicities, that keep getting worse over time. And it's important to remember these toxicities when you care for patients who are on continuous therapies with these BTK inhibitors, in particular ibrutinib. to try and understand if the side effect profile of the newer BTK inhibitors is really better compared to ibrutinib. Two major phase 3 studies were done. This one compared acalabrutinib to ibrutinib in the relapse refractory setting in the high-risk patient population, where on the bottom left you can see that there was no difference in progression-free survival between acalabrutinib and ibrutinib. But on the right you will note that there was a lower incidence of cardiovascular toxicity, particularly atrial fibrillation and hypertension as well, in patients who received acalabrutinib, suggesting that the kinome map with the preclinical data suggesting that acalabrutinib would be a better tolerated and equally efficacious drug does really pan out in the clinic as well. A similar study was done with the use of zanubrutinib, comparing it to ibrutinib in the so-called Alpine study, which is a phase 3 randomized study. And over here also you can see that patients who received zanubrutinib actually had an improvement in progression-free survival, but importantly, similar to acalabrutinib, treatment with zanubrutinib was also associated with a lower risk of cardiovascular toxicity compared to ibrutinib, suggesting that these newer generation BTK inhibitors are likely equally efficacious and less toxic compared to ibrutinib. And now moving on to BCL2 inhibitors in the management of frontline CLL. The CLL14 study on your left, you can see that compared venetoclax and obinutuzumab for a fixed duration of 12 months compared to chlorambucil and obinutuzumab for 12 months actually led to the approval of venetoclax in the frontline management of CLL. Currently, this is the only frontline management of CLL that is time limited for 12 months. Now. And you can clearly see the improvement in the progression-free survival on the blue line compared to the red line. There is no difference in the overall survival, again, because of a crossover that was allowed. On your right, you can see a phase 2 study.
Can you hear me?
Of the combination of ibrutinib and venetoclax, which was done at the MD Anderson Cancer Center by Dr. Nitin Jain and colleagues. And you can see the very high rates of MRD negativity in this patient population, where after 18 cycles of therapy with venetoclax and ibrutinib, you see that close to 70% patients had undetectable MRD in the bone marrow. Now, these are fantastic results that show the power of venetoclax in inducing deep responses in patients with CLL in the frontline setting, and this really allows for time-limited duration of therapy in CLL. At this past ASH meeting, for the first time, we got results from the ongoing CLL13 study, which was presented by Dr. Barbara Eichhorst on behalf of the German CLL study group, where patients were randomly assigned into one of 4 groups, either FCR or BR, or a combination of venetoclax-containing regimens, the first one being with rituximab, the second one being with obinutuzumab, and the third one being with ibrutinib and obinutuzumab. In each of these groups, a total of 230 patients were enrolled, and the primary endpoint was looking at undetectable MRD at month number 15. And as you can see on the right here, the highest proportion of patients that achieved MRD negativity was actually in the triplet combination with obinutuzumab, ibrutinib, and venetoclax, compared to chemoimmunotherapy, where it was about 52%. Interestingly, and again importantly, these are the first data that actually in a head-to-head study compare the amount of MRD negativity that can be achieved with the use of venetoclax and rituximab compared to venetoclax and obinutuzumab. And you can see that it's a stark difference of between 86.5% with venetoclax and obinutuzumab compared to 57% with venetoclax and rituximab. And although not the primary endpoint of this study, it does lay credence to the current practice of continuing with obinutuzumab-containing regimens in the frontline setting and potentially even in the relapse refractory setting as a combination partner for venetoclax to induce deep responses in patients who need therapy. The next study that I'd like to present is the Captivate study. This is an extension of the work that was started using the combination of ibrutinib and venetoclax. In this particular study, there are 2 separate cohorts. The first one is the MRD cohort, and the second is the fixed duration cohort. In both of these study cohorts, patients received 3 cycles of single-agent ibrutinib to an attempt to decrease the amount of TLS risk that a patient may have, and then follow that up with a 12-cycle combination therapy of ibrutinib and venetoclax for a fixed duration of 15 cycles of therapy. After 15 cycles of therapy in the fixed duration cohort, all patients stop treatment, whereas in the MRD-guided cohort, patients undergo secondary randomization based on what their MRD status is. And as you can see over here, approximately 60% patients had confirmed undetectable MRD, whereas approximately 40% patients it was not confirmed. And these patients subsequently undergo secondary randomization to either placebo versus continued ibrutinib if they have confirmed undetectable MRD, versus continued ibrutinib or the continuation of the doublet if the MRD status is not confirmed. At this past meeting, Dr. Ghia and colleagues presented the data for the MRD cohort, where disease-free survival, which is defined as freedom from MRD relapse, was pretty similar whether patients continued with ibrutinib or were on placebo, suggesting that these deep remissions that patients achieve with the attainment of undetectable MRD status really translates into clinical benefit. And similarly, in patients that did not achieve undetectable MRD, there was no difference in the PFS between either the continuation of ibrutinib or ibrutinib and venetoclax. Clearly, these data are very promising. They show that upwards of 95% of patients at the 36-month time point have no evidence of disease progression, and this is after a fixed duration of 15 cycles of therapy. Larger trials need to be done to validate these data and also to make sure that the progression-free survival seen in these patients really holds up for a longer duration of time. And to serve as that confirmatory study, the so-called GLOW study was done that randomized patients to either a combination of ibrutinib and venetoclax according to the Captivate study design, or to chlorambucil or obinutuzumab. And here a total of 211 patients were randomized in this phase 3 study. One thing to note is that in this study, the median age of patients was older at 71 years compared to the Captivate study where patients were much younger. Regardless, over here you can see a very nice improvement in PFS with the use of ibrutinib and venetoclax, which is not surprising compared to chlorambucil and obinutuzumab, and it is likely that this will receive FDA approval for the combination of ibrutinib and venetoclax as fixed duration therapy once these results have been published and have been approved by the FDA. So what are some of the toxicities with BCL2 inhibitors, in particular venetoclax, which is the only agent currently available? Well, the most common and the most feared side effect is tumor lysis syndrome, and there are a variety of risk assessment tools that are available and risk mitigation tools that are available, including the use of allopurinol, hydration, etc., that could be done. There's also the question of neutropenia that can be a problem in these patients. But as you can see that with the CLL14 study, with the frontline use of obinutuzumab prior to venetoclax dose ramp up, the risk of clinical TLS was actually 0. And so that tells us that debulking patients with the use of either an anti-CD20 or ibrutinib or another BTK inhibitor would really be very effective in preventing TLS. Grade 3 to 4 neutropenia is fairly common in these patient population. Actually, it's far worse with the use of combination therapies, but the risk of neutropenic fever appears to be manageable at about 3 to 5%. The third most common toxicity with BCL2 inhibitors is diarrhea, which can be mild to moderate. Actually, a number of my patients, when I see them in practice, actually require dose reduction to help with diarrhea. And I would liberally go down to 300 milligrams or 200 milligrams of venetoclax to try and get them through treatment. What about patients with TP53 disruption? Now, the reason I want to call these patients out separately is because this is an important subgroup of patients. Now, about 5 to 8% of all newly diagnosed patients have TP53 deletion by FISH. An additional 3 to 4% patients may have TP53 mutation in the absence of deletion 17p, and therefore it's important to check for both deletion 17p by FISH and a TP53 mutation by NGS panel to ensure that you have captured any evidence of TP53 disruption. Because as you can see over here on the left, this is the classic donor paper that shows a poor overall survival amongst patients with deletion 17p by FISH. But over the years, we've also seen that patients with TP53 mutation, even in the subclonal setting on the far right in the orange curve, these patients continue to have a poorer overall survival compared to patients where there is no evidence of TP53 mutation, suggesting that looking for this abnormality before you start treatment is very important. Now, the CLL14 study did include patients with TP53 disruption who received venetoclax and obinutuzumab, and as you can see in the solid blue line over here, the median PFS in this group of patients was reached in about 48 to 50 months, suggesting that these patients are likely inevitable to have relapse once they stop treatment after 12 months. In contrast, on the right, you can see a small phase 2 study done at the NIH where patients received continuous ibrutinib therapy, and you can see that the progression-free survival at 6 years was about 61%, suggesting that continuous BTK inhibitor-based therapy may be better in this group of patients to allow patients to maintain disease control without significant evidence of disease progression. So at this past ASH meeting, Dr. Nitin Jain and his colleagues from the MD Anderson presented data on a retrospective analysis of patients with TP53 disruption treated in the frontline setting at their institution, and they found that there was actually a higher proportion of patients, about 1/4, where there was evidence of only a TP53 mutation in the absence of deletion 17p, again suggesting that finding these patients using next generation sequencing is important. There is a smattering of these mutations along the TP53 gene, as is seen over here. And as you can see, similar to the NIH study, the median PFS in this patient population was about 6.5 years, and it did not matter what the variant allele frequency was of these mutations, whether it was less or greater than 10%, or the number of abnormal TP53 or deletion 17p nuclei by FISH, either less or greater than 25%, patients did equally well. So, finally, I just want to touch upon triple therapy combinations. I think we've seen these come through. This is one of the first studies conducted at the Ohio State University where all three agents, including ibrutinib, venetoclax, and obinutuzumab, were combined. And as you can see, it is not surprising that this treatment led to a very high response rate with a very high complete remission and a very high MRD negativity, with a probability of PFS in both the relapse refractory and the treatment naive cohort, along with overall survival being very impressive. Dr. Matt Davids and colleagues presented these data recently with the combination of acalabrutinib, venetoclax, and obinutuzumab, and in this single center study of 37 evaluable patients after cycle 25 of therapy, close to 90% patients achieved MRD negativity. And finally, in a more recent study by Dr. Sumarai and colleagues, the use of zanubrutinib along with venetoclax and obinutuzumab also led to an impressive 90% MRD negativity in the bone marrow after close to 2 years of therapy. Now, it remains to be seen how these triplet therapies line up in comparison to doublet treatments, and these are subject for a number of clinical trial comparisons, including the EA9161, the follow-up alliance study. An important study that is undergoing right now in the German CLL study group is the CLL17 study, where patients will receive ibrutinib and venetoclax compared to venetoclax and obinutuzumab compared to continuous ibrutinib-based therapy. And I think this trial is very important because it will answer a lot of questions with respect to time-limited duration of therapy versus continuous therapy. Similarly, there are studies that are planned or already ongoing with acalabrutinib-based treatments, and these results are going to be eagerly awaited as well. I didn't have time to touch upon the newer non-covalent BTK inhibitors, but pirtobrutinib is one of the more recent non-covalent BTK inhibitors that has shown excellent efficacy in relapse refractory CLL, and this is now being tested in the frontline setting in a study that is comparing it with ibrutinib. So, I shared a lot of data, and I just want to quickly wrap up by saying, how do I approach a patient when I'm thinking about frontline CLL treatment? So I think, there are some pros and cons for each of these approaches. So BTK inhibitors, there are 3 available now. Zanubrutinib will likely receive approval later this year. I generally will not combine them with anti-CD20 monoclonal antibody treatments, except when I am faced with an autoimmune condition or glomerulonephritis, etc. These are very easy to manage. There are no frequent visits necessary. Patients can start treatment and it can be seen in a month or 2 months, and patients generally do quite well. And I prefer this treatment option when there is evidence of a TP53 disruption for all the reasons we have discussed. The downside to ibrutinib therapy is that this is continuous, or any of the BTK inhibitor-based therapy. Now, acalabrutinib and zanubrutinib appear to have less cardiovascular toxicities, but longer follow-up really is necessary to confirm this. There is also the risk of bleeding. Concomitant anticoagulation continues to be a problem. And then there are nuisance low-grade toxicities, including myalgias, headache, etc., that we have to deal with. Now, in contrast, with respect to venetoclax, it's a fixed duration therapy of 1 year. It leads to undetectable MRD rates, and there is potential for retreatment with the same regimen. However, patients need to be seen on a weekly basis for the first 9 weeks as they begin therapy with venetoclax and obinutuzumab, and a lot of patients don't want that. Also, you need to exercise caution using this in patients with neutropenia or have renal dysfunction. Now, finally, the combination of ibrutinib and venetoclax will likely be approved in the frontline therapy later this year, and I think it's a little bit early to tell whether this should be used for patients with TP53 mutation or disruption, but I think it will likely be a very good treatment option for young patients who need therapy regardless of their risk status with respect to CLL. And so this is just one proposed approach where I discuss that if there is evidence of TP53 disruption, you consider a BTK inhibitor-based therapy. But if not, then I think the options really boil down to BTK inhibitor-based therapy versus venetoclax and obinutuzumab, and a lot of the patient preferences, cardiovascular comorbidities or renal comorbidities, etc., really play an important role in choosing the treatment option for our patients. As always, we all strongly consider clinical trial participation in any patient who needs therapy. And again, if one is available, I'd strongly encourage you to consider that in your practice. And with that, I'd like to close. I'd like to thank you for your attention. I'm happy to answer any questions. I'd also like to acknowledge the Mayo CLL group. Thank you.
Thank you very much, Dr. Samir, for this very comprehensive lecture. We will leave the questions and answer for after the second lecture. So our second lecture, our second speaker will be Professor Jennifer Brown. She's well known to you. She's director of CLL Center in Dana-Farber Cancer Institute. She is well known for her interest and contribution in CLL. In international level, she is a member of international workshop on CLL. Professor Jennifer need no more introduction. She will speak to us about MRD-directed therapy in CLL. Thank you, Dr. Jennifer, and welcome, and the mic for you.
Thank you very much for the introduction. Can everyone hear me?
Yes, we can hear you.
Great. I just need my slides, which were going to be shared.
Just a moment, Professor.
Okay. I can start commenting a bit. So the topic of MRD has really come to the fore as we have gotten more and more effective therapies for CLL. Perfect. Here we are. And that you seem to have control. Great. And so you can see on the left historic therapies for CLL, starting with chlorambucil and fludarabine and ranging up to our most effective chemoimmunotherapy. And now we could add venetoclax as well. And so what you have to realize is if patients are not achieving complete remission, they're obviously not going to achieve MRD. And so it's only as the therapies become effective enough for most patients to achieve complete remission that it becomes relevant to look at MRD. And you also need a very good assay for measuring MRD, which is reproducible. And ideally, you also need data demonstrating that the value of MRD is independent of therapy. And in the upper right here, you can see data from the CLL-8 trial, which first demonstrated that undetectable MRD defined as less than 10 to the minus 1 and 10 to the minus 4 cells was strongly predictive of outcome, regardless of whether you were on the FC or the FCR arm of the trial. And in fact, that same trial combined with the CLL-10 trial of the German CLL study group also demonstrated that achieving undetectable MRD was more predictive of progression-free survival than IWCLL response of partial or complete remission. So, as I mentioned, largely actually stemming from the German CLL study group decisions in CLL-8, we define undetectable MRD in CLL as detecting less than 1 CLL cell in 10,000 leukocytes, or less than 10 to the minus 4. And traditionally, this is detected by multicolor flow cytometry, which has been well standardized by the ERIC group and is now used worldwide. One can also do it with ASO, qPCR, or high throughput next generation sequencing, but both of those require a baseline sample in order to achieve the greatest sensitivity post-treatment. When we think about MRD, the idea is to drive the tumor load as low as possible. And the 10 to the minus 4 cutoff, it looks like the slide shifted a bit, but it should be 10 to the minus 4 on the green MRD undetectable line. And if we drive further and further down, the idea is we could eventually even get to cure. And so when we think about what does it mean to have MRD-guided therapy, I think we could think about it 2 ways. Where we have the most data in CLL right now is in trying to optimize our initial therapy to achieve deeper levels of undetectable MRD, which we know in many cases associates with better outcome, and we'll look at a lot of that data. The other question is, if someone finishes frontline therapy without achieving undetectable MRD, does additional of the same therapy or switching to another therapy with the goal of undetectable MRD, 1, does it work? And 2, does it extend progression-free survival? Because those patients may just have worse disease, and that may be reflected in outcome regardless of what we do to try and suppress it. And we really don't know the answer to that latter question in CLL yet. So just running through some quick data, the UK group looked at 10 years worth of treatment in their study group, regardless of the type of treatment, and found that undetectable MRD at the 10 to the minus 4 level strongly predicted best progression-free and overall survival. This was true in first-line therapy or later-line therapy, but the outcomes were better in first-line therapy, as we might expect. And unfortunately, though, it did not overcome the poor prognosis of deletion 17p and 11q. While achieving undetectable MRD in those subgroups did better than those who didn't, the outcomes were still much worse. And unfortunately, I think that we don't have much data changing this observation, at least for 17p at present. So if we turn to our most effective chemoimmunotherapy with FCR, we know from greater than 10-year follow-up from the MD Anderson group that patients with a mutated IGVH can achieve 55% progression-free survival at 12 or more years out. And they've reported that most of these patients have undetectable MRD when evaluated. The initial patients on study were not evaluated for MRD originally, but a subsequent group were. And here we can see the strong effect of undetectable MRD at end of treatment on progression-free survival, with the mutated IGVH patients in blue out at 6 years, up around 90% progression-free survival. Whereas if they're MRD positive, they're down below 50%. And in fact, even the unmutated IGVH patients with MRD undetectable are doing much better than those who have detectable MRD, but are still relapsing steadily. which is likely what we're continuing to see with unmutated patients, although we don't have long enough follow-up of our best regimens yet. Now, what about BTK inhibitors? We just heard a lot about BTK inhibitors, and we know that they don't result in deep remissions on their own, generally. But if you give continuous therapy, this doesn't matter. You can still achieve long progression-free survival. And so it's been assumed that deep remissions don't really matter. But we do have a little bit of data that achieving complete remission with ibrutinib may result in better progression-free survival. This is institutional data from the MD Anderson showing that. And this past ASH, Jan Berger also presented some data from his ibrutinib plus minus rituximab trial in patients with deletion 17p, showing on the right really a marked difference in progression-free survival based on the depth of response achieved, which I think is quite notable. Obviously, we still have limited data on this point, but it raises some interesting questions for thinking about how we treat these patients going forward. So if we really want deep remissions with ibrutinib, actually adding chemoimmunotherapy to date historically was a very good way of doing that. So in the Helios study, ibrutinib plus bendamustine rituximab actually demonstrated that after the 6 months of BR induction, patients still continued to improve their rates of CR and undetectable MRD many months later and even years later after that initial cytoreduction, compared to patients in this case receiving just placebo BR, but it would look not dissimilar compared to patients receiving ibrutinib alone. So the cytoreduction seems to accelerate the ability of ibrutinib to clear disease. And here you can see that does correlate with progression-free survival. Our group did a study combining ibrutinib with FCR in young fit CLL patients, and the median follow-up is now 40 months. And the best rate of bone marrow undetectable MRD in an unselected patient population, including IGVH unmutated and mutated patients, is 84%. The progression-free survival is 97% and overall survival 99%. A really very effective regimen, and not dissimilar from a similar study done in France by the Philo group, which had 79% undetectable MRD and greater than 95% 3-year PFS. The MD Anderson had even better results, but they looked at only IGVH mutated patients. So I think for our very young fit patients, this is an important option to consider. And all the studies stopped therapy, and patients had been off therapy a significant length of time at this follow-up. But what about older patients, patients who are not candidates or not interested in any chemoimmunotherapy? So we just heard about Elevate-TN from Dr. Parikh, but I wanted to highlight that the addition of obinutuzumab to acalabrutinib actually, in the most recent follow-up, improves progression-free survival by 9%, which is quite a lot. And this is associated with an improvement in complete remission to 31% and an improvement in undetectable MRD, which occurred in 38% of the patients with CR. So it seems that obinutuzumab, by again clearing that disease in the setting of the BTK inhibitor, is allowing deeper remissions, CR, and even undetectable MRD, and may in this case be translating to progression-free survival. I think this is a point on which we need more randomized data, but it is quite intriguing. So we heard a couple studies at ASH also looking at add-ins to ibrutinib to get patients off therapy. This one from Memorial added umbralisib, novel PI3 kinase delta and casein kinase 1 epsilon inhibitor, along with ublituximab. And they did achieve a 77% rate of undetectable MRD quite rapidly. Patients came off drugs. And you can see that some did progress relatively soon thereafter, but they did get time off therapy. And the MD Anderson has been adding venetoclax to patients on ibrutinib for 12 months or more. Again, data presented at ASH this year, updated at ASH this year. And we can see that 57% did achieve undetectable MRD at cycle 12, and 53% improved to complete remission. So then the question is, do you use this as an opportunity to stop therapy? If you stop therapy or if you don't, in either case, do you lead to a better progression-free survival? And we don't know that, and we won't know that without randomized data, which unfortunately is not ongoing. Now, what about venetoclax by itself? So the venetoclax rituximab phase 1 study established the principle that you could achieve high rates of bone marrow undetectable MRD in relapsed patients, stop therapy, they could have a time off therapy, relapse, and then resume venetoclax with response. And that led to the Murano trial, which compared venetoclax rituximab with BR in the relapse setting, median of 1 prior regimen. Time-limited therapy stopped at 2 years. Progression-free survival median was 54 months for venetoclax rituximab and was extremely strongly predicted again by MRD at the 10 to the minus fourth level versus high MRD in red. You could see very rapid relapse. Everyone, however, stopped therapy at 2 years. So we don't know that adding more therapy, actually to some extent we do know that adding more therapy to the high MRD patients would probably not be helpful because most of them had rising MRD already on venetoclax. And so they reported now that a longer MRD doubling time, so longer time for the MRD cells to grow back, was predictive of longer PFS, as you might imagine. And that was associated with better disease features. And this is consistent with the idea that not all MRD is created equal, that patients with low risk features who achieve undetectable MRD can have very prolonged remissions, like we saw in the FCR data. The patients with higher risk disease tend to have the disease grow back quicker, don't have as long remissions, but may still have very long remissions off therapy. And that's what we're still learning, I would say. CLL14 compared venetoclax obinutuzumab to chlorambucil obinutuzumab. Median PFS has not been reached. 4-year PFS is 74%. And here again, undetectable MRD, you can see very strongly predictive of PFS in both arms, although the arms start to separate at about 2 years. And here again, as we saw with chemoimmunotherapy, no difference based on complete or partial remission. Undetectable MRD is the strongest predictor of PFS. So what happens with MRD temporally during therapy? So the first 6 months, patients get ven-obin, and then about a third of patients continue to deepen their MRD response in the second 6 months, although most of them achieve their full response in the first 6 months. And so at end of treatment, 74% of the ven-obin patients had peripheral blood undetectable MRD. Of the few who remained MRD positive, about half were having increasing levels of MRD and half were having decreasing levels. So this suggests that a longer duration of therapy might have helped about half of the patients achieve undetectable MRD. The ones whose disease was growing back on would not benefit from more therapy. And here you can see just from end of therapy at cycle 12, we start to see regrowth of MRD in both arms, but more quickly in chlorambucil obinutuzumab because they never get as low as venetoclax obinutuzumab. And again, in this study, high-risk disease features, cells grow back quicker. And deeper remissions in both arms, even with undetectable MRD, mean that venetoclax obinutuzumab has a longer time to MRD conversion compared to chlorambucil obinutuzumab. Now, what about adding ibrutinib to venetoclax? So this is actually an MRD-guided trial where patients with undetectable MRD at cycle 12 of venetoclax discontinued treatment. Those who were still positive added ibrutinib for a year. And actually, about 42% of them achieved undetectable MRD and stopped all treatment. Only 8% of patients had to continue therapy based on still being positive for MRD. So I think this is very intriguing data because we don't really think of BTK inhibitors clearing MRD, but apparently in this setting, the potential synergy between ibrutinib and venetoclax may help patients do that. But again, the goal here is discontinuation of treatment, and we don't really know how outcomes compare if you continued both drugs to stopping them. All right, what about combination data? So this is Clarity, again, one of the first trials looking at MRD-guided therapy. Primary endpoint was MRD eradication at 12 months after ibrutinib venetoclax. We saw steady improvement in MRD undetectability up to 2 years. But adding a third year didn't really add much. So up to 2 years may plateau the improvement in undetectable MRD, even in this early relapse setting. They showed in this study that the rapidity of depletion of MRD was strongly predictive of outcome. That allowed discontinuation of therapy. And the progression-free survival is actually 96% in a relapse study, which is remarkable. At ASH this year, we heard about the HOVON Vision trial, also MRD-guided. After 15 months of ibrutinib venetoclax, patients with undetectable MRD were randomized to continue ibrutinib versus observation and then restart at relapse. So because this is a relapse study, most of the patients did not actually achieve undetectable MRD, stayed on ibrutinib. Those who did achieve it were randomized between the ibrutinib and observation, primary endpoint, PFS 12 months after stopping in the observation group. And here you can see that the observation group did just as well as the continued ibrutinib group. I would like to point out that actually the non-randomized group that was MRD positive did the worst, which reflects on that question I mentioned earlier, that biologically the patients who failed to achieve MRD undetectability may have the worst disease. And here, interestingly, they've been able to retreat 7 patients for recurrent MRD positivity, and 6 out of 7 achieved de novo CR. So limited data, but some of our only data on retreatment with ibrutinib venetoclax. Now, what about frontline? We already heard about Captivate. There's a fixed duration cohort, 15 months, 3 months ibrutinib, 12 of ibrutinib venetoclax, and an MRD guided cohort. Fixed duration cohort, both of these cohorts actually have young, fit patients with some high-risk features but low disease burden. The undetectable MRD rates in the fixed duration cohort were 76% in peripheral blood and 60% in bone marrow, which I should remind you is not very different from CLL14, where blood was 74% and marrow was 57%, interestingly. PFS, of course, is very good at 96% at follow-up of 28 months. Now, what about the MRD guided cohort? So they used very stringent criteria for confirmed undetectable MRD, such that only 58% of patients qualified. And then they were randomized between placebo and ibrutinib. Those who did not qualify were randomized between ibrutinib and ibrutinib venetoclax. So I'd like to draw your attention to the fact that the vast majority of patients in this study stay on indefinite therapy, which I think most of us view as not the goal of dual therapy. We would like to stop. Again, high-risk features, low volume disease. 2-year disease-free rate is 95% in the placebo arm, 100% in the ibrutinib arm for the confirmed undetectable MRD patients. So it does seem safe to stop ibrutinib in those patients. All arms, very good progression-free survival. But again, most of them are on therapy. In the patients with undetectable MRD not confirmed, there is improvement in undetectable MRD in subsequent years of therapy. But again, we need a randomized trial comparing that to stopping probably. Retreatment data is very early, but it's single agent ibrutinib. I think most of us are more interested in ibrutinib venetoclax time-limited retreatment, which we have limited data for. So we heard about GLOW already. Excellent 34-month PFS. Again, so relatively low rates of undetectable MRD, 52% in bone marrow, 55% in blood. Lower actually than CLL14 in a very comparable older patient population. And so far, there's no difference in PFS in the ibrutinib ven arm based on the undetectable MRD, but I think this may be from short follow-up, although we'll see. We heard about Gaia. Co-primary endpoints, they've reported only on the undetectable MRD at month 15 so far. And what I wanted to draw your attention to here was the fact that it's obinutuzumab that drives the rates of undetectable MRD. Rituxan, venetoclax, and chemoimmunotherapy are pretty similar. Obinutuzumab venetoclax is actually quite similar to obinutuzumab venetoclax and ibrutinib, but the ibrutinib added arm actually had a lot of cardiac toxicity. Similar bone marrow to blood concordance. And again, NGS confirms the findings. Interestingly, predictors of undetectable MRD were obinutuzumab containing therapy, being female, or having low tumor burden, unsurprisingly. And that may also correlate with better outcomes. Okay, so the triple drug regimens, IVO was not MRD guided, very high 3-year progression-free survival. AVO is actually MRD guided, but we haven't heard, the bars are not showing up, but the rate of undetectable MRD in bone marrow was 77% here. And there's MRD guidance at one time point, cycle 16 in this study. It serves as the basis for this ongoing phase 3 trial. And the bovine trial looking at zanubrutinib triple drug therapy is MRD guided, and most patients stopped at actually 10 months, which is very early. So it'll be interesting to see if they sustain their responses as well as patients who get extra consolidation. MAGIC trial is using MRD guidance comparing acalabrutinib venetoclax to venetoclax and obinutuzumab. Again, using one specific time point where patients are evaluated, undetectable MRD stops, MRD positivity continues. And so this is how most of the trials that are looking at MRD guidance are designed, because it's easier. Using actually a patient-specific approach, checking every 3 months, is far more complicated. And that's why it is not something that we're seeing much, except in single-center studies. So MRD in general practice, we're still using it basically for prognostic purposes for time-limited therapy. We are getting more randomized trials which have a single time point, allowing patients to stop early or continue to longer therapy based on undetectable MRD. We really have little data as yet about patients who revert to MRD positivity off drug. Can they benefit from retreatment? But we're starting to get a little bit. And remember, MRD does not apply evaluating single agent BTK inhibitors. So then my final summary. We have strong evidence that achieving undetectable MRD is associated with prolonged progression-free survival with both chemoimmunotherapy and venetoclax-based therapy. Studies are ongoing to evaluate whether doing a longer duration of the same therapy to lead to undetectable MRD is helpful, but they're mostly not randomized, so we don't know what the data on impact on PFS would be. We have limited to no evidence that adding additional or different therapy to eradicate persistent MRD is associated with better outcome defined as progression-free survival, and limited evidence that undetectable MRD is associated with better PFS with continuous BTKI therapy, although there's some intriguing hints that I think suggest this could be worth further study. It nonetheless could be useful for adding treatment breaks, though. So I think we still have a ways to go for MRD-driven CLL management, but most of us are quite excited about the future of it, and I think we just need more data. So thank you for your attention.
Thank you so much, Professor Brown, for this elegant talk. We learned a lot from it, and we actually were waiting to hear from you about MRD and CLL, and definitely it gave us a lot of insight. I would like to bring the attention of the audience that questions can be posted on the chat till we receive a few. I have a question for Dr. Samir, if you don't mind. Dr. Samir, we do encounter a few patients with CLL at younger age, and with TP53 or deletion 7 TP mutation. And we wonder if offering allogeneic stem cell transplant is still in the diagram which you showed us at the end of your presentation.
Yeah, thank you very much again for the invitation and the question. I think it's always under consideration, an allogeneic stem cell transplantation, particularly in younger individuals. I think given the long-term PFS that we see with the use of single-agent ibrutinib and with salvage with second sort of generation BTK inhibitors or even venetoclax-based containing regimens, I think it has fallen a little bit out of favor. But I would not completely exclude that possibility. But I don't think we are sort of jumping towards an allogeneic stem cell transplantation in first remission after the use of a BTK inhibitor-based regimen. I'd also be interested to hear what Dr. Brown has to say about this.
Yeah,
I know she has a long-standing interest.
I would agree. We certainly don't jump to allogeneic transplantation like we used to. I mean, it obviously also depends on what therapies you have available. You need to have at least BTK inhibitors and BCL2 inhibitors available, which I think you do. But I do, once a very young patient progresses on a BTK inhibitor, I start worrying about them, because then at that point, the median time benefit they're likely to get out of venetoclax is only about 2 years. If they achieve undetectable MRD on venetoclax, it might be longer. We don't really know. And so sometimes in that context, I'll monitor the MRD. But most of them, in my experience, don't achieve undetectable MRD. And so I do start thinking about it then, CAR T or allo potentially. And this is very young patients. You know, it's sort of a gradation of age.
Yes, absolutely. Thank you. Another question to Professor Brown. We understand right now an undetectable MRD is still not considered as cure if we are allowed to say that for CLL. But how frequent do we need to monitor the MRD in patients on long-term, for example, BTK inhibitor?
Right. Well, so I don't monitor at all on patients on long-term BTK inhibitors. I tried to make that point in my talk that long-term BTK inhibitors are not really associated with much likelihood of achieving undetectable MRD at all. And as long as the patient stays on the therapy, they have a prolonged progression-free survival, even with persistent disease. So it's really more time-limited therapies, chemoimmunotherapy or venetoclax-based regimens or venetoclax-based combinations where MRD is helpful. But even then, you know, we mostly look at end of treatment for prognostic purposes. It's not clear that monitoring is that meaningful if you're not intervening. We have clinical trials where we're testing now monitoring with early intervention, but we're not doing it in practice. And just on the question of sort of the significance of MRD with respect to cure in CLL, you know, I think the FCR data for IGVH mutated patients does suggest that that subgroup may be potentially cured with that regimen with very long follow-up. We don't have long enough data with venetoclax-based regimens to comment on that yet, but that type of duration of remission with mutated IGVH is not something we've established that we can achieve in unmutated IGVH patients, even if they're MRD undetectable. In 17p patients, that much less so. Undetectable MRD in 17p patients is not as meaningful because their disease grows back more quickly, as we've seen with both of the German studies. So we have to understand that the interpretation varies with the prognostic features and biology of the disease.
I mean, with the diversity of many medications right now to offer a patient with CLL, I'm coming from a myeloma perspective where people are also commencing quadruple therapy on frontline therapy. I'm really happy to hear about the triplet therapy, but adding, for example, idelalisib, which is a medication that I rarely used in my practice from before, but is it still possible for these patients to just to deepen any kind of response to CLL treatment?
You know, I certainly wouldn't use idelalisib to deepen response. It can have a role for treatment, continuous therapy. You know, at this point, because BTK inhibitors and BCL2 inhibitors are so effective and well tolerated, it's generally after both of those lines of therapy. And the main issue is we don't know a lot about how much activity there is of PI3 kinase inhibitors in that setting. We really need more data. We also have the newer drug coming along, umbralisib, which I did show some data showing that adding that with ublituximab and anti-CD20 to ibrutinib can actually help deepen response. But we don't actually have data with that drug either in the post-BTK BCL2 setting, which is when it would be most likely used.
And I'd just like to add that I think until we see randomized data that show that, you know, triplets are really better than doublets, I think we got to be a little bit careful. And I think there are several major phase 3 studies that are ongoing that are comparing triplet-based regimens to doublets. And I think until we see a clear benefit in both progression-free survival as well as toxicity, actually, I think we should be careful in using them in routine practice outside of a clinical trial.
I agree completely. And I would go maybe even further to say that I'm not sure that BTK inhibitor, BCL2 inhibitor combination is better, for example, than venetoclax or obinutuzumab based on, you know, the MRD data. You know, and we really need head-to-head trials, which we're going, the MAGIC trial is a head-to-head of that combination or similar regimen.
I have one question, Dr. Athman, for Dr. Samir. I'm a transplanter. I'm usually with transplant, but usually we debate and discuss if patient with CLL failed ibrutinib and he achieved remission on venetoclax. So usually the debate, people will say if he failed venetoclax in future, you will not have option for therapy, take him now for transplant. Usually here comes the question of CAR T. So where are we now on CAR T cell for CLL?
Yeah, that's a very good question. I think we actually debate the same thing amongst ourselves. I think a lot depends on the availability of CAR T as an option for the patient. So if there's a clinical trial available, I think getting to a CAR T based approach makes a lot of sense, and reserving allogeneic stem cell transplant for after CAR T failure if that occurs. But on the flip side, there are patients who are, in the 65 to 70 age group where, they may not remain an allogeneic stem cell transplant candidate in a few years. then that actually adds to the discussion of whether we should just directly proceed to an allogeneic stem cell transplant. So it's a very complicated and a very individualized discussion. I don't know if there is one right answer as to how you approach. But I think in general, when a patient has disease progression on ibrutinib and is on venetoclax, I think that's really when cellular therapy becomes a major point of discussion for all these patients.
Thank you, Dr. Samir. Thank you, Professor Brown. I think we're overdue at the time of the Q&A discussion time. And this actually, by this, we conclude the session for the leukemia today. I'd like also to thank all the attendees for presenting or being around today. It has been a lengthy day, lengthy Saturday. We started with many satellite symposium. We did 2 workshops as well, and we are ending with this session. Tomorrow, Sunday, it's a working day in Saudi Arabia. So by the end of the workday, people can join the Congress starting at 7 p.m. It's a lymphoma day. So, and including also one session for myeloma. So I hope to see everyone tomorrow evening, and have a good night. Have a good morning there.
Thank you.
Thank you. Bye.
Thank you all. Thanks for the speaker. And we are glad to have more than 4,000 attendees until the last minute. As mentioned by Dr. Rado, it has been a long day since 9 o'clock in the morning and until now 9 p.m. So please join us tomorrow, 7 p.m. For the new day 4 of our conference. Thank you, everybody, and have a good night.